I think let's move on to the second session immediately. We are running short of time. So I'll request the panel of experts to join us on stage. Dr. Fazlul Aziz Mia, Dr. Hikmatullah, Dr. Ambar Malik, Dr. Akhtar Ali Bandisha, Dr. Jalaluddin Achakzai, Dr. Zafarul Islam, and Dr. Nazir Maiman. So please kindly join us on stage. As we are already running short of time, we have 10 minutes for every talk and 5 minutes for question answer. So we'll take that 5-minute question answer to just 1 to 2 minutes, 2-3 question answer, and then continue with talk. And fortunately, I have first talk in this session. And that is on heart failure updates. Okay, let's start with the presentation. Can we have slide display on the screen? That's just an introduction. So we are today going to discuss HFrEF updates. Now, heart failure covering in 10 minutes is very difficult. So just quickly go through the guidelines and just taking out the main chunk which are new, although we know a lot about heart failure. In definition, previously we thought of just inability of heart to pump the blood. But it's not that case. Clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the ventricle to fill with or eject blood. So it's both filling as well as ejection. That really broaden the spectrum of heart failure, and we see how then we can classify and include various categories into it. The terminologies nowadays used to describe heart failure, although stages, because we considered everything which lead to heart failure is heart failure. So starting from stage A as a risk factor, stage B with some structural changes but not symptoms yet, stage C with or with existing or with symptoms in the past, and D the end stage heart failure. And these both conditions, stage C and D, very high morbidity and mortalities. That's why we are considering this A, B and giving it importance so that we can stop things here or prolong the course from here. Then within stage C, you have different trajectories in terms of patients' clinical status, which is new onset heart failure, resolution of symptoms, that pre-existing heart failure but presently asymptomatic, persistent heart failure, irrespective of treatment, patient is continuing to have symptoms, signs and other, and then worsening in spite of doing everything. And it's important to identify these trajectories because management depends on identifying the trajectory of patient as well, along with diagnosis of heart failure. That's the one in terms of clinical. Then on the basis of ejection fraction, we have divided heart failure into different categories. HFrEF, which will be covered today by me. HFpEF, marginally reduced EF. So according to ejection fraction, there is another classification. And one more thing added to this classification is HFIMPEF. All those who developed heart failure or marginally reduced heart failure in the past, but now they are almost normal. There are some conditions where it's reversible. It's cardiomyopathy, myocarditis, a lot of things. So you have to consider your patient's category according to this classification as well. Then comes purely HFrEF, which is reduced EF. Now reduced ejection fraction previously thought of just, and usually juniors thus consider this condition as heart failure as a diagnosis. It's a syndrome. And this syndrome is secondary to multiple things in terms of etiology. And that is very important to identify what you are dealing with. There are multiple things which can act as like precursor as a stage A, precipitant as like dipping patient from one clinical trajectory to the other. So a very comprehensive assessment is needed when you're dealing with a patient with heart failure to identify everything. Initially basics, clinical examination, physical clinical history examination, ECG, NT-proBNP, echography. NT-proBNP is important because sometimes your cardiography is showing EF normal and you aren't able to assess various features of that diastolic dysfunction or poor filling, then this will be guiding you that your patient has something wrong with filling, not just ejection. And then you'll go for that preserve ejection fraction. So NT-proBNP is important here. Conventionally, we used to offer our patient ACE, beta blocker, MRA, and then came ARNI. And I still see a lot of prescription following this standard of like incrementation of treatment. Nowadays, we have totally different management strategies. But the issue is people are reluctant to add on all those drugs simultaneously, especially without diabetes. So wait and see, kis tarah, kahan, and that's the crux. How to start and up titrate your medication in heart failure patient as early as possible. Now it's considered to be at least within 4 to 6 weeks, you have to have your patient on all those 4 pillars of heart failure treatment. And some even advocate this 4 pillars should be really added into the treatment right within hospital as early as possible. What are those? ARNI, beta blocker, MRA, SGLT2. So we have to give all these 4 medications to our patient. Now, the key is how to incorporate all these things in your patient management strategy. And then after that, you can offer others that will be covered by Dr. Azmat regarding devices and other things. So not touching on those. And then this is ESC 2023. They want acute heart failure intensive strategy of guideline directed medical treatment initiation and rapid titration. That's the only new thing. Otherwise, we all know that those 4 pillars are the crux of heart failure management when we are considering medical treatment. But that's the key. Otherwise, you have additional things as well that we'll quickly discuss. And in conclusion, we can say that these 4s should be there. And then according to phenotype, patient characteristics, tailoring other medication along with these 4 pillars, which are diuretic according to volume status. So in every patient at every visit, it's important to assess the volume status. Is your patient hyper, hypo, or even sometime like hypovolemic patient receiving diuretic, hypervolemic not receiving adequate dosages. So diuretic again important, ivabradine, hydrazine nitrates, omective mecarbil, vericiguat in a specific group of patients where your conventional medications is not fulfilling your objectives. Time is short, so just want to go to that scheme, how to incorporate all 4 medication in your patient as early as possible. That was the conventional sequencing. ACE, ARB, beta blocker, MRA, angiotensin receptor neprisin inhibitor, SGLT2 inhibitor. But now, usually what the guidelines suggest, you can start with beta blocker, SGLT2 inhibitor, seeing your patient is tolerating in terms of hemodynamics, adequate pressure, adequate rate, then ARB or ARNI, then potassium and all other things. If they are allowing you, then MRA. And for that, that's the important to identify your patient's phenotype characteristics. In terms of hemodynamics, like rate, you can have a patient with low rate, normal rate, or slightly higher rate. And according to heart failure management, 70 is above is a higher rate. You have to have a baseline heart rate less than 70. 60, 70 adequate, less than 60, 50 is low heart rate. Similarly, blood pressure, 90 to 60, above that or below that. Then CKD, potassium status and renal status. That's again important when you're incorporating these 4 drugs. And lastly, patient's rhythm, AF or sinus rhythm. These 4 characteristics you have to look for in every heart failure patient at every visit to really decide which drugs first and which afterward. Adding guidelines therapy to admitted patient. Usually we stop all the drugs because hypertensive, volume overloaded. Then you have to restart combination of diuretic and MRA first because that purely affect your volume. Then once your patient has a euvolumic status, then according to renal status, potassium rate, other comorbidity, rhythm, ischemia, non-ischemia, then switch to ACE-ARB or beta blocker. And SGLT2 should be added before discharge once your patient needing no diuretic at all or is close to euvolumic status. That should be the sequencing in inpatient as early as possible. Certainly you have to look for these things when you're adding these 4 medications. Just a quick review. Beta blocker, clinic euvolumic, hemodynamically stable. Green. Approaching euvolumia, yes, you can add on. Once you are thinking your patient is in positive trends, he has slightly volume overload state, but approaching euvolumia, then you can add on your beta blocker. But significant volume overload, poor perfusion, hypotension, no. Similarly, MRA, GFR greater than 30, potassium 5, yes, you can. History of hyperkalemia in the background, yellow. Close monitoring needed. Hyperkalemia, low GFR, no MRA. ARNI again, GFR, potassium. Now, pressure also important along with it. Then, borderline pressure, yellow. Red, less than 30, greater than 5 potassium. Blood pressure less than 90, no ARNI. SGLT2 is a drug which you can offer to multiple phenotype characteristics patient. Even GFR up to 20 you can give. Less than 20, yes, you can't give. Type 1, history of recurrent UTIs, DKA, you can't give. So this is very important to identify. So that means the crux is identifying your patient characteristics right from the beginning till end at every visit to identify which drug need to be added, discontinued, up titrated or down titrated in your patient. And that is the crux. It is recommended that evidence-based oral medication treatment be administered before discharge. Ideally, these all should be before discharge. If not, then at least 4 to 6 weeks. So a close follow-up after discharge within 1 week to add on or increment these drugs. Conclusion, diagnosing heart failure, classifying it, identifying etiology, its trajectory, clinical status, these all are important, not just diagnosing heart failure. Similarly, baseline and sequential changes in hemodynamics, rate, rhythm, blood pressure, renal status for rapid up titration of medication is again very much needed. Thank you for your patience listening. We can take 1 or 2 more questions, then we can move on to the second talk of the session.
Can I make a comment, please? As expected, a wonderful presentation. I think you mentioned iron in the management of this condition. Obviously, those who are a bit low on iron. I just want to add one point of caution that certain medications can cause fluid retention. We have to address those issues as well. Like many of our patients are elderly and are on some painkillers which can cause fluid retention. So that should be reviewed also. Thank you.
Ideally, you can speak volumes on heart failure management. In 10 minutes, it's really difficult to take care of everything, but it's a very important concept need to be added on when you're managing heart failure patients. All the aggravator in terms of volume overload, salt and retention.
फवाद आपने दरिया को कूजे में बंद कर दिया. This was a very nice simplification and still comprehensive definition and understanding of the heart failure. Thank you.
Ji, thank you very much. It was excellent talk. I just want to ask most of the patients present to us with the volume overload. That's the initial phase of the patients. And in the diuretic treatment regime, we just seeing the MRAs. So usually we are not going to depend on the MRAs solely for the heart failure treatment. What's the combination of the initial diuretic therapy do you recommend or have the good experience along with the furosemide and adding, because sometimes the renal patients are not responsive that much to the furosemide. So what's the addition of the diuretics initially, what you can explain for the better response to give the volume offload?
We are lucky that most of our patients are non-compliant or on inappropriate treatment as such. And their main issue is that volume overload. Just 2-3 shots of IV furosemide make them really symptom-free. But rarely you can come across patients who have renal issue, you're just IV shots are not working in those patients. Then usually second step is infusion of IV furosemide to push your renals if they are not helping you in decongesting patient. Then there are multiple, then again GFR is adequate for that, metalozone, not end-stage renal, like mild, moderate kind of renal dysfunction, then furosemide and metalozone combination we used to use in severely volume overload. So hope that will.
Acetazolamide combination with the furosemide also gives the good results.
Yeah, it's possible. But usually we use these kind of sequence. So I think with that we'll move on to our next presentation. And for that I'll request Dr. Azmat Hayat, and he'll be talking on cardiac device therapy in heart failure game changer. Right patient choice dictates the outcome. And I hope he will follow my footstep, just 11 minutes presentation and 1 or 2 questions to catch our time.
Rahman Rahim. Even hopefully less than that. So, yeah. So, I always try to interject in the heart failure session and interject with the cure for it. And that's why I always say, and obviously these devices do cure, they are a curative. So, these are some numbers. Unfortunately, this is all Western data. We don't have a Pakistani data. But if you see, these are the numbers. And similarly, in heart failure, sudden cardiac death is one of the dreadful modality of death. So this is how the heart failure patient journey is being navigated or has been navigated. So as you see, we started from here, moved on to here, then lot of these drugs, and then some of these drugs on which my very esteemed colleague just probably talked about. But I'm going to touch this portion, the first 3 of them. The 4th is obviously surgical-based procedure. Now, in a failing heart, the problem is that once the heart starts failing or is about to fail or begins to fail, then it gets dilated. Now, when it gets dilated, it gets desynchronized. And by desynchronization, the basic problem is that the 4 walls of the, especially the LV, they don't act in synchronization. So the idea or the concept started from these resynchronization options was to rectify the problem. And the problem has been, as I said, desynchrony in a failing heart. So the options, these are the 3 options. Obviously this is the oldest of them. This one is intermediate and this is the latest of all. So I'll just show you all 3 with some practical demonstration. So have a look at this ECG. And remember, all of them are patients with LV dysfunction. So have a look at this ECG. This is pre-HIS. And then this is how we implant a HIS bundle. It's like a standard pacemaker. The difference is that basically we implant this lead and catch the HIS from the right side. So the idea is, and the idea was at that time, was to catch the HIS, and if you catch HIS, then the rest of the current spreads through the normal conduction system. And hence, the idea was that it would resynchronize the heart. There were some pitfalls for it. Just a quick glimpse, you can see the difference between the 2 echoes. And most importantly, have a look at this ECG. So just by capture of the HIS, the QRS has got tremendously narrowed down. And resultantly, the LV function improved, symptomatic improvement, NYHA class improvement, and quality of life improvement. However, there were some pitfalls in this HIS bundle pacing. And naturally, one of them was the lead dislodgement. Complexity, by and large, means that you need an electrophysiologist to implant this, because this needs a demonstration of a His capture. So the problem has been solved probably by the introduction of left bundle area pacing. Now, how this happens is that the same process, but in this procedure, rather than His bundle, we catch the left bundle from the right side. This is a diagrammatic representation, and I'll just show you a video, a floor of it soon. And conceptually, as I said, the fault lies in the left bundle. A failing heart, disruption of left bundle, hence the broader left bundle branch block. So this was one of our patient, and as you can see, he has got a left bundle branch, a moderate LV. Have a look at this ECG. This was pre-left bundle ECG. Now this is how the procedure is being done. Have a look at it. So this is a standard atrial lead. This was a temporary pacemaker, and this is a left bundle lead. The difference is between this and His bundle is, so the lead is placed for the His from the right side, on the right side septum. And you need a His signal on the EP machine. For the left bundle, we cross, this is a screw-in lead, so we cross the septum, go into the septum and catch the left bundle. How do we know that we have caught the left bundle? Is because of the help of the A, surface ECG, and B, intracardiac signals. For this you need an EP machine. So intracardiac signals tell you how much shorten have you made this QRS. So the result is, again, I'll just show you in a short while. So these are a couple of the echo images, and have a look at this ECG. You can see, remarkable. And obviously these patients are being followed up, and as we follow them, we see difference in their NYHA class, we see difference in their echo findings, we see difference in the quality of life, and so on. Well, this is the very well known of all. I'm sure most of you in this hall knows a lot about at least this device. So how does it work? As I just explained, the concept is that in this one, we place an additional lead which is called an LV lead, and it optimizes all four chambers. So the concept is not only it reverses the left bundle, but it optimizes our four chambers into synchronization. So it is an AA synchronization, AV synchronization, and a VV synchronization. These are some of the impacts on the life by CRT. This is again just a diagrammatic representation. I'll just show you the videos. So this is how the standard device here, just below the subclavian, just below the clavicle, and then the additional tool is this left LV lead. Now this is the tricky business. So I'll show you how do we do it. So this is another pre-CRT ECG. Just couple of them, just for demonstration purposes. Now the trick in this patient is, and that's the most difficult part, is to catch the coronary sinus, go into the coronary sinus and catch the posterolateral vein. Now this is a representation of one of the patient heart, the CT images of it, and the venous side of it, not the arterial side. This was the patient whom I'm about to show you now. This is a posterolateral branch, and the idea is to catch the posterolateral branch, because this is the furthest branch of the veins on the LV, and it produces resynchronization. So this is a fluoroscopic image, an atrial lead, a ventricular lead, and the LV lead. This is an APU image, and the rest of the two images you can see the LAO and the other projection. Have a look at this ECG. Remarkable difference in QRS. Remember, all these QRSs, technically we try to catch QRS more than 150, and post-procedure normally normalizes to less than 120. some of the echo differentiation. Now, have a look at this data. So this data is a comparison of bi-V versus left bundle. And slowly and steadily, I assume left bundle is catching up. I'll just tell you that in which patients we decide which modality.
So just a humble reminder, 1 minute remaining.
Okay, I am on time actually. So this is the data of a CRT versus bi-V. It's a new data. So same device, but with a defibrillator. So CRT with a defibrillator. And this is the post-CRT ECG. Just for comparison, though it doesn't improves the heart failure, but it would be incomplete to talk about an ICD. As I said, this is prevention of sudden cardiac death. So this was a patient, sinus ECG, signal average showing strong late potentials and a tachy ECG. This is how it is implanted. And this is an AFIC data. So as you can see that these are CRT numbers, but left bundle is catching up. So slowly and steadily left bundle is catching up. And with this, right on time.
Thank you. Now we can take 1 or 2 questions and then we'll move on to the next talk. Yes, Dr. Shehbaz, as always.
I did practice to be on time, GC.
Asmat,
Sir.
thank you very much. A good demonstration of the left bundle branch pacing and CRT. In patients as a preoperative evaluation, if you do a global longitudinal strain, you will actually be able to see what is the dyssynchrony that you see in the left ventricle, number one. And the second part of it is that in the posterolateral area where you're going to implant the LV lead, there if the longitudinal strain is much reduced, it is like a scar tissue. And in that case, you would agree that it is not going to benefit the patient.
What Sir, Professor Shehbaz is referring to is at one time the emphasis was doing on echo, finding out scars and avoiding those areas which are scarred, so as not to put the lead there. But recent data has come of late which actually shows that irrespective of that scar in that wall, if you catch and reverse the left bundle, it changes the life remarkably. So lately, the point is LV dysfunction, NYHA class 2, 3 and above, and a very wide and bizarre QRS. These are the 3 requirements which has to be met. If no shortness of breath, no CRT. Okay. If QRS is narrow, no CRT.
Okay.
So the strongest parameter are NYHA class, broad QRS, that's the strongest. But I agree with you, these studies have been done and are being done, but probably significance-wise, the data supports benefit on those patients who are more short of breath, NYHA class-wise.
So it's
Professor
symptoms.
Asmat, you told a difference between CRT and left bundle branch pacing. So left bundle branch pacing is coming up, as you said.
Ji, sir.
Is it a more simple procedure than CRT, or has it an edge over that procedure, or what are the differences?
Sir, simple, it's cheaper, number one. It's 1/3 of price of CRT. B, at the moment, the guidelines suggest, if CRT fails, go for left bundle pacing. It is not simple as per se, but it is simpler for an electrophysiologist, because the implantation is not a problem. Any doctor who implants a pacemaker can do it, but the problem is you need an EP machine, an EP recording machine, intracardiac signals, because you need to catch the left bundle. So a standard implanter who do not understand EP machine will not know the difference between pacing from just from the right side or going into the septum, catching the left bundle, and hence producing that current.
Thank you, Dr. Azmat. So you need expertise for that. Thank you. Thank you again.
so much.
Now let's move on to our next presentation, which is by Dr. Nusrat Ara Majid, Diastology, Don't Throw Out Mac, Madam. And hope Madam is usually always on time. वो बता देंगे मैडम. ये स्लाइड चेंजर दे दें मैडम को. माइक ऑन कर दें.
कैसे स्लाइड कैसे चेंज करते हैं प्लीज कोई बता दे मुझे.
ये मैडम, ये स्लाइड चेंजर मैडम को दे दो ना यार.
हैं?
ये ले.
इससे टाइम दे.
और यू कैन क्लिक डायरेक्टली ऑन कंप्यूटर और यू कैन चेंज विद स्लाइड
मुझे
चेंजर.
इतना इस तरह नहीं करना आता. प्लीज आप खड़े होके कर दें इधर. ठीक है. ओके. यू नो यू हैव हर्ड माय टॉपिक द अदर day before I was at AFIC for an echo workshop, and when one of the speakers began to talk on diastolic dysfunction, he looked at me and he said, "ये तो हमारी मैडम का फेवरेट है." I said, "Dr. Sahab, ये मेरा फेवरेट नहीं, मुझे इसके साथ इश्क है." And there are genuine reasons for that. You will see very simple slides. These are made by, I have made them by my hand, and whatever I say will come from within my heart, with a request to the cardiologists to understand the pathophysiology of this very important subject. कैसे करूँगी? ये कैसे? Okay. So without wasting time, you know, heart failure is very common and the prevalence is very high. According to WHO estimate, in next decade or so, more than 75, please no disturbance. Next 75% beds of any medical or cardiac units will be occupied by patients with heart failure. So that imposes a tremendous burden on society in terms of manpower, finances, etc. So what is the need? The need is to prevent its occurrence. And as you know, the causes are hypertension, especially myocardial infarction. And the beauty is that you have to you have to intervene at the level of asymptomatic left ventricular dysfunction and do not let it degenerate into frank heart failure. And for that, it is very important to understand how does diastolic dysfunction affect. Normal diastolic dysfunction is determined by very important, you will understand different phases to understand that. First is rate of myocardial relaxation, then is your left atrial pressure, then is the left ventricular pressure and compliance, and then a very important factor is the loading conditions of the heart. ये तो हो ही नहीं रहा भाई.
एक थोड़ी सी क्लिक कर दें, ये साइड पे विंडो खुली हुई है. नहीं नहीं, पहले कंप्यूटर पे ये क्लिक कर दें. बस नाउ अब करेगा.
अब यूं करूं? Okay, I will not go into the basic, you know, EA, how is it formed. And again, I've talked about these phases so many times that I think many of you may be sick of that. Sometimes even I get irritated. Why am I talking about so many times? But these are the different phases. And, you know, these are 5-6 slides that I made during my stay at Mayo Clinic, Rochester, Minnesota, working with Dr. Tajik and his team. So I've put symptoms, LV size, left ventricular and diastolic pressure, and correlation with the pulmonary vein velocities. Now this slide is very important. I know sometimes during these meetings, patients come from periphery, and this is the M mode of mitral area. If you don't have access to pulse Doppler and other fancy things like TDI, please pay attention to this thing. Can you see that in early systole, and you must always do your echoes with ECG, early systole there is a bump. That means the pressure in left ventricle is so high, the moment mitral valve opens. This is called, Japanese would call it B- formation, and it is a sure sign of left ventricular, elevated left ventricular pressure. ये फिर खराब हो गया भाई. Okay. Then you know the problem with these different phases was, it was a very useful concept. You could non-invasively estimate left ventricular and diastolic pressure. But the problem was with loading condition. I often mention, when I was at Mayo, a young boy of 18 came and he had the echo, the lady reported that he has grade 1 diastolic dysfunction. And those days, a lady, very humble, Liv Hatley, he was a Dutch lady, she was sitting there and he said, "Doctor, there is no other signs or symptoms of a cardiac disease. Why don't you inquire about preceding gastroenteritis or any other?" Oh, then they took history and he had a severe bout of gastroenteritis that made him look like grade 1 diastolic dysfunction. They gave him a little bit of fluid and it turned back to normal. Similarly, in cases of hyperthyroidism, fever, you will get a pattern of pseudonormal, and actually it is because of the hemodynamics. Right? Then people thought that we must exclude the effect of loading conditions, and there came the idea of TDI. There it had problems, then strain and strain rate imaging. Then finally, you know, this is Mount Fuji in Japan. It's a beautiful side, ye park. This is my favorite place. So this diastolic dysfunction for me is like strolling here and enjoying the beauty of nature. But then once I was told that I must talk about a forgotten entity, that is MAC. So it was rather difficult, so I had to. Now what is MAC? You know, this is the mitral annular calcification, which is a chronic degenerative process involving calcification of the fibrous base of the valve, and it has a reported prevalence of 10%. And it shares the same pathophysiology. It shares the pathophysiology with atherosclerosis. So you know the risk factors for atherosclerosis. And given these risk factors, these patients with MAC are at a very high risk of developing concomitant diastolic dysfunction. And then, you know, we need a reliable method of estimating left ventricular and diastolic pressure in the setting of MAC. As you know, that during last 2 decades, a lot of work has been done on diastology, and as a matter of fact, a new subject has been introduced. It is called diastology. And then we learned during these 2 decades that it is easy to estimate left ventricular and diastolic pressure by studying the ratio of mitral inflow velocity divided by your mitral annulus velocity. But it was not easy. ये देखो थोड़ा ऊपर कैसे जाएंगे? ऊपर, ऊपर. अच्छा ठीक ये. नहीं और ऊपर. ये बड़ा मसला. ऊपर. Hate this. ऊपर. नीचे आओ ना, तुम तो शुरू में ले गए. हाँ हाँ बस ठीक, आगे आगे चलो. Okay. Then you know, आपको मैं बता रही थी कि वो specific measure E/E prime, that was easy to calculate that. But this approach was rather difficult in the setting of MAC. Why? Because calcification of the annulus may increase mitral inflow velocity. At the same time, due to restrictive effect of calcification at the annulus, your E prime will be reduced. So you cannot have an effective, aage karo zara. So in these cases, people reverted to the conventional EA, that is जो हमारी normal Doppler पे E और A velocity होती थी. But then it was easy in severe cases. In moderate cases, even that concept was difficult to apply. And then, you know, in year 2017 in JACC, a study was published where this author performed echo Doppler on 50, and then he correlated these parameters with right and left heart catheterization. And his findings were that E/E' does not correlate with left ventricular and diastolic pressure. And in these cases, conventional EA is more useful. So EA ratio performed well in subjects with severe cases where the restriction was more than 1.8. आगे करो, बस ठीक है, ठीक वही था. But the problem was in these intermediate cases. आगे. Yeah, then ये उसने किया. I will not go into that. This is a case of a lady which had the intermediate type of MAC. आगे करें. So here in intermediate groups, bus, they thought that you can take help from isovolumic relaxation time. This is the time interval between aortic valve closure and mitral opening, and it directly correlates to the left ventricular relaxation. And as its time duration shortens, that means the left ventricular and diastolic pressure is very high. So patients जो severe और वो थे उनमें ये काम कर देगा. So this study states that IVRT alone may not be useful in all these patients. Then आगे करें वो people thought of doing CT in these patients, and still, a lot needs to be done. That is why they say it is important. Don't throw out math. Thank you.
Thank you very much. I think, madam, we can take one or two questions. You can stay there. We can take two questions as we are running short of time. If there are any questions or comments. Yes, doctor. But Dr. Shehbaz is not allowed to ask.
No question. I think the topic is little new and many may not be familiar with that, except Dr. Shehbaz maybe. डॉक्टर साहब जल्दी करें, मैंने तो खत्म कर दिया आपका.
नहीं, आप थोड़ा सा रिलैक्स करें. और in patients who have mitral valve annular calcification, इनके अंदर जो आपका E by E prime है वो स्टैंड नहीं करेगा. तो आप जो आपने यहाँ बताया है वो ये कि IVRT जो है आइसोवॉल्यूमिक रिलैक्सेशन टाइम, वो अगर आप कैलकुलेट करेंगे और वो शॉर्ट हो जाए तो दैट विल इंडिकेट लेफ्ट वेंट्रिकुलर फिलिंग प्रेशर्स. तो डायस्टोलिक डिसफंक्शन के अंदर द क्वेश्चन व्हिच आई वांट टू आस्क इज स्ट्रेस एको का क्या रोल होगा?
डॉक्टर साहब, क्योंकि आई वाज रेफरिंग टू दिस पर्टिकुलर एंटिटी मैक, तो इसमें सीटी का भी अभी रोल मेंशन किया जा रहा है और बहुत सी चीज़ें की जा रही हैं. दैट इज़ व्हाई इन द एंड दे से डोंट थ्रो आउट मैक. So right now, I may not be answer your question. Role definitely है, लेकिन we still need a lot of studies. Okay, thank you.
Thank you, madam. Now let's move on to the next presentation. A challenging task to restrict Dr. Shehbaz to 10 minutes. Sir, next talk is by Dr. Shehbaz Qureshi. He will be talking about HFpEF, treatment and evaluation. नहीं सर, हम टाइम पे चल रहे हैं. अच्छा, 1 घंटे में ख़त्म. 11 बजे शुरू हुआ था. हाँ, आईडी तो 11:30. आधे घंटे लेट.
थैंक यू वेरी मच. फवाद, ज़रा थोड़ा सा एहतियात से, क्योंकि मुझे जब आप इंटरजेक्ट करते हो तो पीवीसी शुरू हो जाती हैं, सो प्लीज बी अ लिटिल केयरफुल.
डॉक्टर अजमत मौजूद है सर, बीटी भी हो गया तो कोई बात नहीं.
हार्ट फेलियर विद प्रिजर्व्ड इजेक्शन फ्रैक्शन जो है वो इज नॉट अ टॉपिक फॉर आई थिंक 8 minutes. द हार्ट फेलियर फॉर with preserved ejection fraction, the art is long and the time is short in this case. So basically, when we talk about heart failure with preserved ejection fraction, we have to understand the universal definition of heart failure. Number one, what it is, the signs and symptoms of heart failure with structural and functional changes, and then the ejection fraction, which is normal, which is more than 50%. And this affects, if there are 64 million people the world over having heart failure with preserved ejection fraction, they are about 32 million people worldwide. So the problem is enormous, and that is what we need to understand, how we can diagnose it, what is the pathophysiological basis of it, and what is the treatment that can be carried out in these patients with heart failure with preserved ejection fraction. There are three categories: the heart failure with preserved ejection fraction, having an ejection fraction of 50%, and symptoms of heart failure, and evidence of elevated filling pressure, which you will find non-invasively. You will treat it as heart failure with preserved ejection fraction. The left ventricular ejection fraction may stay stable or decline, but you continue to treat it as heart failure with reduced ejection fraction if the LVEF declines to less than 50%. Then you have the middle child. You have the mid-range heart failure, which is from 41 to 50% ejection fraction. You need to treat it. And then you have heart failure with reduced ejection fraction, which was talked about in detail by Fawad. It is an increasingly common cause of exercise tolerance. That is what heart failure with preserved ejection fraction is. Linked to obesity and sedentary behavior. Despite understanding the advances in understanding of the pathophysiological mechanism, diagnosis and treatment, heart failure with preserved ejection fraction continues to be under-recognized. And we need a lot of more research as to how to manage these patients, because you have a lot of masqueraders. You have patients with hypertrophic cardiomyopathy. You have patients with amyloidosis, which are with ejection fraction which is above normal, and there you have to treat those patients according to the individual conditions. I'll just touch upon the pathophysiological basis. It could be because of hypertension. And in arterial hypertension, you have the changes of left ventricular hypertrophy, you have fibrosis, and you have post-capillary pulmonary hypertension. This will lead to heart failure with preserved ejection fraction. But that is not the whole story. There are other comorbid conditions which are pro-inflammatory. Microvascular endothelial cell inflammation, we discussed this in the morning in the Go Red for Women session. But here also, it is not always the inflammation which is there in patients with heart failure with preserved ejection fraction. And there are very few studies which show us how to treat these patients, because if you use nitrates, if you use sildenafil, they are negative, they are not important, they do not show the benefit. However, the anti-inflammatory studies are there, and as yet there is no consensus on that. But then the pathophysiological basis for it is because of the multi-center system, multi-system involvement in heart failure with preserved ejection fraction. You have different phenogroups in this particular category, and therefore you manage these patients according to the phenogroups that you see in these patients. When we talk about the diagnostic algorithm, remember you need to have heart failure symptoms, risk factors for heart failure, and preserved ejection fraction. They should be present. For example, you should have obesity, they should be older age, hypertensive, and diabetes. These are the risk factors which are there. Then you need to evaluate it by echo to see that if the ejection fraction is more than 50%, and consider the non-cardiac conditions like, for example, lung conditions, anemia, deconditioning, and identify specific treatable conditions like amyloidosis and hypertrophic cardiomyopathy. Then in the assessment, you also need to look at the history in case there are patients who have overt congestion or unexplained dyspnea. Then you look at the history in these patients, you look at the physical examination, complete blood count, electrolytes, electrocardiogram, chest radiograph, and other findings. echo findings, and you will be able to assess the possible presence of heart failure with preserved ejection fraction. NT-proBNP and proBNP are not very helpful in heart failure with preserved ejection fraction because they can be false positive and they can be false negative also. This is the algorithm which we follow in these patients to establish the diagnosis of heart failure with preserved ejection fraction. You have the different scores, the H2P, FPEF score, or the heart failure association score, which you can accordingly calculate the risk scores and then determine whether these patients have heart failure with preserved ejection fraction. These are the different masqueraders that you have in patients with heart failure with preserved ejection fraction: restrictive cardiomyopathy, hypertrophic cardiomyopathy, storage disease, other etiologies, primary RV failure, and pericardial disease. All these can mimic heart failure with preserved ejection fraction. Then you have diastolic dysfunction, whether you can have the E by E prime, which is raised, and that will be giving you the LV filling pressures. JVP is raised, there is cardiomegaly. This will give you the clinical presentation of heart failure with preserved ejection fraction. If you look at the trajectory, the temporal disease progression with preserved heart failure with preserved ejection fraction, gradually you will see that the chambers dilate and they stop functioning. So you have to see these changes in the parameters. When we look at the different phenotypes of heart failure with normal ejection fraction, apart from the masqueraders, you also have a lot of overlap in patients who are obese, cardiometabolic, arterial stiffening, pulmonary vascular disease, ischemic, LA myopathy, for example, those patients who have atrial fibrillation. All these patients, they will present to you with heart failure with preserved ejection fraction. There have been a lot of randomized controlled trials in these patients, and only very few have shown the benefit, like Emperor Preserved and Deliver. These were the positive trials. All other trials were negative in these patients with heart failure with preserved ejection fraction. How would you treat them? What you need to do is treat hypertension, treat diabetes, obesity, chronic kidney disease, coronary artery disease, coronary microvascular dysfunction, atrial fibrillation, extremely important, and chronotropic incompetence. The mainstay of the treatment are the SGLT2 inhibitors, dapagliflozin and empagliflozin in your patients. Then a heart failure, self-care education, aerobic exercise. Cardiac rehabilitation is very important in these patients with heart failure with preserved ejection fraction. And you need to actually exercise these patients and they will benefit. So the fifth pillar is always there, both in heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. This is very, very important. It's a 1A indication, both in heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Whenever there is congestion, you will use loop diuretics and you'll manage hypertension according to the guidelines.
So just a humble reminder, 1 minute remaining.
Manage atrial fibrillation according to the atrial fibrillation guidelines. MRAs are there, they can be used. TopCat study showed us some benefit, but not very equivocal benefit with MRAs. Equivocal benefit with ARNI. You can use them in your patients, and it was shown in one of the trials where there was a borderline benefit in patients in women and in those with an ejection fraction which was less than 57%. What are potentially dangerous or harmful drugs? Don't use nitrates in these patients. Don't use sildenafil. And soluble guanylate cyclase stimulators like Vericiguat, they don't have any role in these patients with heart failure with preserved ejection fraction. So this is the management algorithm which is suggested in patients with heart failure with preserved ejection fraction. And you will see that loop diuretics, SGLT2 inhibitors, MRAs in a small percentage of patients, ARNI in a small percentage of patients, which you can use. And always think about the fifth pillar, which is exercise. All patients need to be exercised. use SGLT2 inhibitors early on in your patients with heart failure with preserved ejection fraction. The role in heart failure with reduced ejection fraction and mid-range ejection fraction is also there. Use them first in your patients. ARNI can be used in these patients. It has a role, but it is still not very unequivocal. Then MRAs like spironolactone, eplerenone, and diuretic agents as they are needed. So basically, it is not the 4 pillars. Remember, it is the 5 pillars in heart failure with both ejection fraction, which is preserved, and with reduced ejection fraction. Thank you for your attention.
Thank you, sir. Now, let's move on to the next talk. We'll take
one
question
question.
answer after the session.
One question.
This last talk remaining.
Only one question.
Okay, sir.
Okay, sir. Professor Cheba, you told us there was some right ventricular failures also, look like diastolic failure. What about very common condition in Pakistan is the constrictive pericarditis and cardiac tamponade, in which there are right ventricular failures and other things, and LV ejection fraction is normal.
One of the slides which I showed to you was with the masqueraders, those which mimic heart failure with preserved ejection fraction, and one of them is constrictive pericarditis.
Hypertrophic cardiomyopathy and
Amyloidosis,
very uncommon.
all these,
Very
they are uncommon, but you have patients with
Yes.
Pericarditis, constrictive pericarditis,
Yes.
with atrial fibrillation,
Yes.
with hypertension, with obesity, old age, women, and the elderly age group, you have this.
Thank you.
Okay, thank you, sir. Now, let's move on to the next presentation by Dr. Intisarul Haq, establishing a heart transplant unit in third world country, the way forward. Okay to sir.
Sure. Thank you very much.
नहीं मैं देता हूँ
Enable editing करने तो शायद उससे हो जाएगा.
लगता है ट्रांसप्लांट का डोनर नहीं मिल रहा है.
बिल्कुल इतना ही मुश्किल है सर. उससे आगे भी ठीक है. Bismillahirrahmanirrahim. Assalamu alaikum. First of all, I would like to thank the organizers for giving me an opportunity to present in front of this August forum. Just a couple of months ago, we get to hear this news on the newspaper, and it's definitely stirred our mind. On one hand, we got very excited because of the huge sacrifice this brave lady has made. But on the other hand, we got equally disappointed because a readily available organ could not be retrieved because of the reason that we were not ready at that time. In a few months' time, we get to see this news where a 19-year-old girl goes to our neighboring country, India, and gets a heart transplant. Circumstances in India are no different than Pakistan because they started their program in 1994, and following passing of legislation in 25 years ago, they are conducting heart transplant very regularly. And currently they are doing around 190 cases in a year.
So I'm Dr. Intisar, working as a congenital cardiac surgeon in AFIC, standing in front of you to see the reasons why we are lagging behind in this specific program and what could be the way forward. Being clinicians, we have seen so many of despairing faces of patients in end-stage heart failure. The best thing that we can offer them is optimizing their medical therapy and offer them admission in our hospital. But I just want to ask this forum that how many of us have really thought of a heart transplant as a definitive treatment for these patients? To start a program, we need to establish two basic facts. First of all, see the need assessment, and then establish the feasibility of the program. This article, which is based from Pakistan, which shows that every year around 1,000 patients are added in heart failure pool, which is a very significant number. Statistics based on UK have shown that the prevalence of the disease is around 2% with an incidence of around 0.15%. Again, this article shows that heart failure as well as acute myocardial infarctions are two devastating diagnoses, as well as they have got very disappointing prognosis as well. Now coming to the feasibility, all we need to do is that conduct a research and see that how many patients in our nearby tertiary care facilities are declared brain dead, because these are the potential donors that we can avail. The current cardiac services which are available in major cities have got adequate setup available, and just with the help of few modifications, we can use them as a transplant center as well. So my next question is that what do you think is the biggest hurdle in this cardiac transplant? I think this is the basic awareness of general public about the miseries and difficulties that a heart failure patient is facing. This awareness is also lacking on part of healthcare system, because if they realize that just by giving a heart transplant and making the heart transplant possible, we can really reduce the miseries of these patients. Our social attitudes and beliefs do interfere in our decision making about cardiac transplantation and accepting brain death. And religious challenges is another parameter that we have to cross. So considering all these challenges, we quite often think to ourselves that this is a very, very huge challenge that we can face, because it involves political struggle, negotiations with HOTA, and huge financial constraints. To address all these issues, I think we need to adopt a multi-pronged strategy. We need to create public awareness. We need to reduce social ambiguities, and religious challenges should be met, and then have a political dialogue. Once we win this political dialogue, only then we will be able to pass the legislation and get rid of the financial constraints that are in our way. For a sensible religious scholar, this single ayat suffices, which explains that saving one human life is like saving the whole humanity. We need to get involved in religious scholars who have got special medical background, because these are the people who can get convinced easily, and they have got better comprehension of the subject. Our prime focus should be creating the awareness. For this, we need to use the social media and print media very effectively. We not only use to show the programs which show the miseries of the patient, but also give them an encouragement so that they are convinced for organ donation and heart donation. We also need to dispel the myths which commonly exist in general public. People who have got their relatives as a brain dead patients, they all quite often think that the patient is in coma, and one fine morning he might get up and live a normal life. So we have to fight that challenge as well. Once we run this campaign for at least 5 to 6 months, then we need to open up a portal or a platform which starts booking the patients. I mean, we start getting voluntary donors on that platform. From here, we will see that how effective our campaign was. If we find out that our campaign was not effective and we did not get an adequate response, then we might increase this campaign for another 4 to 6 months' time. Now, we quite often think that legal issues is another battle that we have to fight, which might require passing of legislation and identifying the registering body. But it's interesting to find out that on political front, a lot many laws have already been passed. The last law that was passed was in 2018, and that amendment bill was passed by Senate in 2018, which really smoothens our way, and the political struggle might not prove that difficult. Again, NADRA has already been designated as transplant heart organ donor body. The last bill that was passed by Punjab government in 2022 is another landmark step which allows swab transplantation. So once we are able to convince the politicians, they are the one who can really drive this program very well. And if at all we can make them pass a bill which allows us for presumed consent, that will be a major breakthrough, which will soften our way. As far as the organization of transplant program is concerned, we need to establish 3 centers, which mainly focuses on north, middle, and south of Pakistan. We need to have a very close collaboration with the recent vicinity hospitals so that we can identify brain dead people in time. We need to start the talks in time with their relatives, convince them, and retrieve the organ in time without wasting time. Heart transplant program cannot work in isolation. We need to have a very close partnership and collaboration with local healthcare organizations. We need to have detailed talks with government agencies like NADRA and HOTA, and then we need to have parallel negotiations with our international program which are running in the West. One of the hospitals that we can look for is Newcastle Hospital, who are always there to help us out. They have visited AFIC, and they're always available for extending their help. Once these Western hospitals are accessed, then we can establish the protocols for pre-transplant evaluation, for patient selection criteria, organ allocation, and immunosuppression protocols. An average heart transplant might cost 10 to 12 Pakistani million rupees, but starting and establishing and smoothly running a program does require substantial resources, financial resources. So again, political forum has to be used on that, and we need to look for the guidance and help from the government agencies, philanthropic organizations, various aid agencies, and international aid agencies who can help us in building up this to get rid of this financial constraint. And again, once we are running the program regularly running this program, then we need to make sure that quality control is met, and we need to focus on our standards as well.
So just 1 minute remaining.
Sir, thank you. We as cardiac fraternity know that we have to work as a team. If we think that we have a solo flight for this cardiac transplant program, I'm sure that this will not come, this will not be possible. So we have to, again, for the cardiac transplant program, we have to work purely as a team and together. Establishing a cardiac transplant program is a very difficult endeavor, especially in a developing country. But if we have a strong leadership, we have a clear direction, then of course we can follow this, and we will be successful if we just stick to this point that we have to stick together and work as a team. Thank you very much.
Thank you, Dr. Intisar. We can take 1 or 2 questions and comments. Yes, Dr. Kiani.
We started this program way back in 2010 in AFIC.
So this is the news. Sorry, agar aap news dikha de, bilkul news was also published, sir. But unfortunately, somehow we lost the track at that time.
Yeah, and then I think we sent our team to UK for training, how to retrieve the donor's organ, and then we trained all our anesthetists and surgeons over there. The whole logistics team was trained over there, and then we ran a program, and we, I think, had 10 runs for the transplant. We actually couldn't find the match, and they couldn't match. I think there was an incompatibility or something like that. General Asif was surgeon at that time, and we last day, I think, before my leaving that command, I thought that we'd be able to do 1 transplant surgery, but it's not very difficult. I think it's a doable thing, and if still is planned in my mind, and one should do it, whether it's AFRC or some other big institute, and it's a doable thing. And the figure you quoted at that time, it was more than 15 to 20 millions overseas in UK and USA, but in Pakistan it only cost 1 to 1.5 million. So that was the kind of a difference between the actual cost overseas in UK or USA and in Pakistan. So it's a doable thing, it's a very simple thing, but I think the logistics are very important, your protocols are very important, that has to be done, and still I think this is, since I've been appointed as advisor to Punjab government on health, so this is my first priority. So I think any center in Punjab, maybe it's Rawalpindi Institute of Cardiology, Punjab Institute of Cardiology, or anywhere, and then I think there has to be a coordination between different institutes, and this is doable. And hopefully, I think you will hear a good news in the near future, inshallah. Thank you.
Thank you, Dr. Kiani.
Just further to that, there was eventually one person who family decided to donate the organ. And once they decided to donate, the eye people, the kidney people, they all turned up. And then the family just said, "Ki hamare bachche ka bachega kya?" So, you know, we are like, there's such a, we still import eye corneal implants from overseas. So our population is totally not ready for this. And the other issue was that we would get donors from the head trauma in the RGH and Holy Family hospitals. And there the treatment was so pathetic that, you know, they would have no facility. It was really miserable, like any other hospital. And so when we would come and go and talk to them, they would say, "Dil lene wale aa gaye." And so, yeah, "Dil lene wale aa gaye na." Haan, dena kya? And so they felt that ya to wo jo treat kar rahe the na, sabse bada person to communicate with them is the treating physician in the head trauma center. And once the family feels that they've done everything possible for the child or the person, they'll be more than willing to listen to him. Look, they tried their best, then now, okay, fine, why not? You know, so that's where, with a very big loose end, sir, where the head trauma center also has to be as at par with the transplant center, where people should get the feeling that everything possible is done, and now they're saying we're going to pull the plug on the machine, so why not? So I think we have to cover the whole end of the spectrum. And
we did a lot of work.
Yeah, I know.
We had a psychologist with us, then we had one dedicated doctor, and it was very difficult to convince the donors. It's very difficult, but I think finally, I think you keep on, that perseverance is the, I think, key to everything.
And the ambulance would take like 6 minutes to get from Holy Family to AFIC?
Pakistan Aviation, Pakistan Air Force, they were at our disposal. They thought if they had to transport the donor heart to AFIC, they will do that. So we had everything in reach, and we could manage to pick the donor's heart from everywhere in Pakistan. So it's doable, and people are very, very helpful. Once you talk to them, then I think the people, they come forward.
Thank you, sir.
Sir, I feel very encouraged. I think we were discussing in Peshawar Institute of Cardiology about how to start with it. Another aspect of that will be to develop our heart failure program. Our heart failure treatment is right now in infancy or even before infancy. We have to work very hard on our heart failure program. Abroad, there's a fellowship which is dedicated to it. There's a special department for it. So I think that is one aspect that we have to increase the life, or the candidates who are for heart failure, we look after them. And then I think if we 4 institutes get together, Peshawar, PIC, AFIC, RIC, PIC from Lahore, Karachi, NICVD. I think if we all get together, and I feel very encouraged in Azhar saying that it is doable, so I think we should, and I should be requesting the commandant of AFIC to take an initiative and get us all together to do it, inshallah ta'ala. Excellent talk. Thank you.
So, sir, I think we are running short of time. Quick comments, sir, quick. Dr. Shahbaz.
I think I agree with Professor Hafiz as far as the fellowship program is concerned. Regards heart failure program, it should be done. That is number one. The second is that when you have a transplant program, what about the left ventricular assist devices? which should also be started, because that is what you need as a bridge to the transplant. So I think before you have a transplant, you start with the left ventricular assist devices, and thereby you will be able to form some logistics for it.
Obviously. Okay, with that, we are
Just-
going
just
to end
one
our session.
comment,
Please.
last comment. About the heart failure program, I appreciate it, but never forget the rehabilitation in heart failure program, because this is where we are lacking mostly.
This is lost. You see, the last one is that someone, Pakistani, did a pig transplant, a pig heart transplant in USA. You don't need all these things if the pig heart is available for Pakistani people.
Okay, sir, thank you. Let's quick comment from our expert, then we'll end the session and hand over to the next group. Yes, sir.
Cardiac failure is the syndrome which the whole cardiology, whether it is electrophysiology, congenital heart disease, cardiac surgery, the aim of the whole cardiology is to prevent cardiac failure. The end of all disease is cardiac failure. So all have to work together to prevent cardiac failure, because treatment is very difficult and transplant खुदा करे कि हो जाए, but much difficult.
Thank you for providing it. The heart transplant, I think I'm very positive about it. The ground is fertile for the heart transplant. The people are donating kidneys. Before that, people used to be very much skeptic about the donation of the organs. Now, most of the people are agreed in. The corneal transplant is there, liver transplant. So I think we have to work on the public level, awareness, and we should get hold of the religious scholars who have a background knowledge, as Dr. Sab said, and we can interpret the Islamic teaching to make the people understand that what is right, what is wrong, what is needed. And I hope that working on the public level and through electronic media and through social media, we will be able to create a grounds for it. Once that is done, at the same time on the legal and the government side, the effort should be continued. Thank you.
Thank you very much. Everyone has actually contributed in the diagnosis and management of heart failure, and definitely the patients of heart failure, they'll keep on increasing. The last talk by Dr. Intisar that has covered all potential problems which are hindering the start of this transplant program, but they are doable things. And as General Kani has mentioned that he is on it, and I hope he will be able to establish a team to rectify all these issues in a team fashion actually. The people sitting on that team will be handling the legal issues, will be handling the issues of the public campaign and all those things. And it is a doable thing, because we Pakistanis, we are doing rest of the transplants, why not the cardiac transplant? And it's technically it is easier than those transplants, but it's a team actually. The team needed to be formed, and Professor Kiani and rest of the people, I hope so, they will make a difference in that.
I think thanks to all for attending the session. Move on to the next session.
So thank you very much. The next session we are going to start coronary artery disease management update, and I would request the panel of experts to kindly take the chair. Major General Retired Azhar Mahmood Kiani, Major General Retired Farhan Tayyab, Professor Tahir Saghir, Professor Abidullah, Professor Javed Akbar Sial, Brigadier Asif Nadeem. I would request the first speaker, Professor Dr. Mansoor Ahmed, to kindly deliver his talk on chronic coronary syndrome.
Assalamu alaikum. It's wonderful being here. मेरा time अभी start नहीं हुआ. Number one, thank you all the generals, ladies and gentlemen. पहली चीज़ तो ये, there was too many comments in the last talk, तो मैं I'll take my time on that, on transplant. Number one, ईदी साहब की जब death हुई, तो do you know कि उनकी नमाज जनाजा किसी ने नहीं पढ़ाई? All the Maulvis actually refused कि इसने अपनी आंखें डोनेट कर दी हैं, जो कि हराम है. तो आपकी फौज से मलीर से बुलाना पड़ा था मौलवी साहब को, उन्होंने नमाज जनाजा पढ़ाई. नंबर टू, ट्रांसप्लांट इज़ नॉट सच अ सिंपल स्टफ. ट्रांसप्लांट में, बिकॉज आई वाज, जो यूके का फर्स्ट ट्रांसप्लांट हुआ था वो हमारा पेशेंट था. आई एम सॉरी, आई एम टेकिंग टाइम, बट आई थिंक इट्स वेरी इंपॉर्टेंट. इसमें आपके पास HLA टाइपिंग का बैंक होता है, और जहाँ पर किसी की, जहाँ से डोनेटेड हार्ट मिलता है, उसके टिश्यू मैचिंग होती है और फिर आप बुलाते हैं. तो यू हैव टू गो थ्रू लॉट्स ऑफ लॉजिस्टिक्स. हमारे यहाँ प्रेजेंट डे ट्रांसप्लांट जो हो रहा है ब्लड ग्रुप पे होता है, जिसमें सक्सेस रेट इज़ नॉट दैट हाई. तो दैट इज़ नंबर वन. एंड फाइनली, द ग्रेट ट्रांसप्लांट सर्जन Magdi Yaqub. I have never seen a standing ovation that I have seen for Magdi for anybody else ever. And Magdi said, I used to do bypasses and I was always stressful. Yeah, it's so difficult, this may happen, that may happen. When I did my first transplant, I had to wake myself up, yeah, there is no stress. Because you pick an organ, you stitch here, stitch there, and it's done. And then he said, when I did my first heart and lung transplant, I was still surprised, it was so simple. And when I did my heart, lung, and liver transplant, he said, literally, I picked up this thing from one frame, put it on the other frame, and tie at one end and the other end. So technically, surgery may be very simple, but I think it's the tissue matching and logistics which is not always so easy. Present day, heart transplant की waiting list is almost 6 to 8 years. और उसकी वजह यही है कि tissue match करना is not always easy. Plus, in my time when I was in training, there were lots of accidents, क्योंकि ड्रिंकिंग ड्राइविंग पे बैन नहीं था. अब जब से ये हुआ है, एक्सीडेंट्स कम हो गए यंग लोगों के, प्लस एक्सीडेंट्स होते भी हैं तो ट्रीटमेंट इज सो गुड दैट मेजॉरिटी इज सेव्ड. तो आई थिंक देयर विल बी प्रॉब्लम्स, बट आई एम ग्लैड यू आर प्लानिंग इट. Whatever, we have to take a start. So I wanted to make these comments before I start my talk. Okay, now my time may start. Let's go. So
You already spent 3 minutes.
Yes, I told you कि my time. Okay, जितनी बातें करोगे मैं अपना इतना ही delay करूँगा time. Thank you. Sorry about that. Apologies. Okay, now this is the topic, chronic coronary syndrome. What is this, yaar? In 2013, it was called, ESC called it chronic stable angina. We all knew about stable angina and unstable long time ago. In 2019, they changed it to chronic coronary syndrome. Now what happened? Last year, the Americans came up with a new word, that is chronic coronary disease, CCD. So now we are talking about it. I'll go through both very rapidly. What is this? What is not? You all understand everything. So, oh dear, this doesn't, I can't read it myself. So anyway, suspected and established are somebody who is already known to have coronary disease. They are all chronic coronary syndromes, unless they become unstable or acute coronary syndrome. This may be LV dysfunction, heart failure, and all those things. My God. Now, I've just received this talk. Anyway, if the resting ECG is abnormal, you can assume that this patient has got chronic coronary disease, and you don't need to do a stress test on these people to diagnose this patient. Okay, echocardiography, we know wall motion abnormalities, LV dysfunctions, we should suspect coronary disease in those patients. I'll go rapidly because there are many slides, and I just have to do a little comparison between 2019 and 2023. Exercise ECG was class 1, level C. And of course, furthermore, stress echocardiography, spectra, or PET, or contrast echocardiography, or CMR. So coronary angiography was again class 1 in a certain group of patients where they needed. I'm just going to go, oh my God, yeah. Okay, management, it's more or less the same, not very big difference. Lifestyle, pharmacological, and revascularization, these are the basic theme of management of coronary disease. Lifestyle, I won't spend too much time on that. Diet, I think I always enjoy talking on diet because the kind of diet we prescribe to our patient, ye band, wo band, phika, ubla hua khana, for God's sake, if you look into the data, more people die on such a diet than they survive. They need nourishment. Calorie intake has to be there. Fat intake is mandatory. You cut down fat intake from 40% of your calorie in normal diet to 35%, and if you are very strict, to 30%. And you got to use oil which is rich in polyunsaturated fats or monosaturated fats. Okay, again, I think I'll move on to now 2023. I'll move. Here there is differences that ivabradine in ESC is part of the management, whereas I'll go through next. In ASC, this is class 3. Okay, so ranolazine is there. Trimetazine is not available in ACC or AHA. These are the difference between across the Atlantic. Aspirin is there. Anticoagulation, this is all the same. I'll just move on to statin again. Most of us do not prescribe high intensity statins. I wonder really why. People come to me when I give high dose statin. Many people will come back to me, ji fala doctor ne kam kar diya, usne itna kar diya, usne kaha tumhe ye ho jayega, tumhe wo ho jayega, and he says body pains ho rahe hain. Now when you explain to them the benefit of statin is the only group of drug which is proved to slow down or prevent the progression of the disease. This is the only drug, and once you explain it to the patient and once the patient understands, they stop complaining. And I usually follow a target of LDL of 50 or less, and people remain healthy even if it's 40 or even less than 40. Now, we come to this, they have described it as chronic coronary disease. Let's move on. It's the same thing, they are emphasizing on certain things, which is lifestyle mainly, diagnostic evaluation. Now, they recommend the diagnostic evaluation should be done only in those patients where there is symptomatic change or functional change. Otherwise, don't do any further tests, just carry on, follow up, and they advise follow up once a year at least. So it's more of the same thing, and you can actually do any kind of stress test or even angiogram if you think feasible. So it's all allowed as class 1. Okay, I won't spend time on that. Risk stratification you have to do before you decide to treat them for long term. They should have long term planning, and that is where risk stratification is important. Okay. Now again, general approach, won't spend time on that. Now this is something which may not be available to us. There are 4, 5, 6, 7, 8, 9, 10 things. And in our part of the world, one person has to behave like 10 different people. So it's the physician alone. Your patient expect कि जी सारा काम डॉक्टर ने करना है, डाइट भी करना है, एक्सरसाइज भी बताना है, प्रोटोकॉल वगैरह. This is where a system is needed, which may be available to FIC, but I don't think anywhere else. And in fact, NICBD is trying to evolve this system. And I've seen they have rehab center as well as awareness sessions they perform. And in fact, preventive cardiology, they have developed a department. So team-based approach, this is, again, more or less repeat of the same thing. So many persons, you have to collaborate in your own mind. Nutrition, again, nutrition is very, very important. This is class 1 here, and this is where it says that they actually use lean protein. हम लोग कह देते हैं beef बंद, गोश्त बंद, सब कुछ बंद. Now where do we get it? I don't know, because it's not science. They mention lean protein, that is meat without fat, lean meat. Of course, overall we must cut down animal food intake and prefer vegetable origin diet, which is very true, but there is no indication कि should stop it altogether. तो उबला हुआ खाना, लौकी खिलाना हमारे यहाँ तो कहते हैं कि सुन्नत भी है, और बेचारे मरीज का बड़ा बुरा हाल होता है. So this is again a very, very important part of my treatment that I advise, because if you do not feed them well, if they do not get enough nourishment, they are not going to act. They will be in bed, and lying in bed is very dangerous. Again, I would like to, I don't know if how many of you actually understand this thing. Since 1950, when after first myocardial infarction, 95% people were stand retired. And 30% of them used to die because bed rest was minimum 3 months. And during those 3 months, many people used to die. Most of them DVT and pulmonary embolism. And most of the time when we see people are going back to normal, 95% people go back to work, a lot of it, most of it is actually related to early ambulation. Mobility, exercise, and that's what keeps us going. Okay. Again, it says if you look at the, इधर है कुछ दिखाने का? Yeah. Yeah, pointer. If you look at that, they have actually classified as monosaturated as a very high content, although the Europeans do not mention monosaturated at all. They mention only polyunsaturated. So 20%, 10%, and saturated fat should be less than 10% of the total fat intake. That is the advice. Okay. Tobacco, of course, it must go. That includes vaping as well. Alcohol, there was a time in 80s and 90s when people used to say कि यार थोड़ा सा alcohol ले लिया करो अच्छा होता है. But now we know even a small quantity of alcohol is not good for myocardium. You may have your coronaries going for a while, but it does affect your myocardium. And this has been known since early 80s. So it is not recommended. Nobody will recommend. And if somebody is taking it, ask them to cut it down to whatever limit they have set. Well, of course, this was, when I came back to Pakistan, this was a no-go for a myocardial infarction. I wrote a rehabilitation program, and in that I had mentioned. So I remember late Sayyid Aslam साहब जब अपनी किताब लिख रहे थे तो उन्होंने कहा यार मुझे भेज दो तुमने बड़ा अच्छा लिखा है खास तौर से इस सब्जेक्ट पे तो I think इनकी किसी बुक में रेफरेंस दिया हुआ है इसका. Lipid management, I think here this is very important. To me, LDL of 50 or less in established coronary disease to prevent the progression of the disease. Because acute episodes, nobody knows when it happens, but this is the only group of drug which stabilizes. So much so that if it doesn't work, then you can add ezetimibe, and if that doesn't work, you can have PCSK9, and hopefully we'll have inclisiran very soon in our country, which has proved to be very beneficial. At least PCSK9 per data bhi hai. Inclisiran ka data is in the process, but whatever data it is there, it is safe. mRNA-based medicine, and all our new medicines are going to be mRNA-based. That is, so they will be targeted specifically rather than affecting the whole system.
1 minute left.
Thank you. There won't be much. Very high risk, we all know about it. In fact, I want to raise a few questions after that, rather than talking about all this, because most of you do know, just the heading should tell you what I'm trying to say. There are a few questions that I have to put to you. This is another issue. Whenever I prescribe aspirin or clopidogrel, every other person would make it a combination of aspirin and clopidogrel both. I don't know why. It is not really needed in stable patients. You have to use it in acute coronary, post-acute coronary syndrome, in post-PCI, in post-CABG, but not after that. So we have to be very careful about dual antiplatelet beta blockers. We know the indications. Colchicine, yes, this is another. There was Colcott trial and there are 2 other trials because they are targeting inflammation these days. because we all have dealt with LDLs and everything, so inflammation is the only thing left, and colchicine has shown some benefit and they've already included. So medical therapy, yeah. Yeah, look here, class 3 is ivabradine, whereas ESC says it is 1A, sorry, 2A, I beg your pardon, yeah. Refractory angina, no, revascularization is just the same. Whenever you do it, a lesion that needs to be done should be done. Prognostic lesions should be taken care of first, whereas non-prognostic lesions may be dealt with medically. Okay, revascularization ke to hum sare expert hain. So let's keep going. Okay, now my question is, नहीं पूछूं, out of course है.
Yes, I think it's been a great presentation. The stable coronary artery disease is a whole subject of its own.
Yep.
So if everyone agrees, we will take the question towards the end, if that's okay.
Just one short comment. We can divide these patients into two groups. One of those who have been diagnosed, and the other first group which have not been diagnosed. जो कि diagnosed नहीं, उनके we can pray them they should seek medical advice and get them diagnosed. And those who have been diagnosed should follow the principles of secondary prevention. That's it.
Thank you. इतना मैंने 10 मिनट खराब किया. But at the end of the day, all of you have been a very good audience. Thank you very much for not questioning.
Thank you, sir, for the nice talk. Next, I would request Professor Major General Retired Suhail Aziz to please give a talk on NSTEMI management advances and update.
Assalamu alaikum. Bismillahirrahmanirrahim. Everybody has been talking so much about time, so I'm going to be talking just about time. How do I start? Yeah. Okay, we all know about atheroma and what role it has in acute coronary syndrome, that there's the lipid core and you get a thrombus formation now, whether it's occlusive or not, depends upon the size of it and how the flow across it happens. This is something we need to know, the different types of acute MIs. We tend not to look at them, but there's a type 2 myocardial infarction, which is secondary to ischemic imbalance. Now, you need to keep that in mind during the talk. So the reason for early invasive strategy is that we identify the cause and then we stabilize the plaque and prevent further ischemic episodes. We all know that acute MI is a very devastating event, and we all know that its immediate reperfusion is the established fact, and there's no doubt on that. Similarly, in non-STEMI, we also know that in appropriate patient, it's a well-established mode of treatment that we need to do early preservation. But the real question where there's a gap in the evidence, and that is what is the optimal timing of invasive strategy? That is controversial. And there's some evidence that high-risk patients benefit from early invasive strategy. Now, I was talking to Colonel Azhar, who just got promoted, once again, and Dr. Bilal, and they said कि सर आप एक स्लाइड में बस सारा लेक्चर कर दें. So जिसने एक स्लाइड देखनी है वो उस आखिरी पैरे को देखे. Some evidence that high-risk patients benefit from early invasive strategy. Now that is something to focus on. अगर आप कहते हैं तो मैं आगे भी चलता हूँ, वरना we can like stop here. चले. But the thing is that you must know that there's some data which is going on, and actually this is the only modality or mode of treatment in जिसमें ESC, AHA, and European, and they've all downclassed the evidence from 1A to 2A. And that has been basically because of some recent randomized trial, and even the trial was not evidence enough. The meta-analysis which they did in the discussion, that suggested that there's only a difference in the rate of recurrent ischemia with the randomized trial, and the time is still very controversial. So this gap in evidence concerns the optimal timing of angiography and revascularization. It needs further elaboration. And if you look at all the data, we'll find that data and the real life experience are very different in non-STEMI. And we're going to talk about that also. Some of you may know this guy. And when he was asked about the weapons of mass destruction, he said, we know there are knowns. These are things we know. We also know there are known unknowns. That is to say, we know there is something we do not know. There are also unknowns. The ones we don't know. And that kind of elaborates on the data we have on non-STEMI timing also. So all that, the reason being that all the clinical trials that we've seen and we've done so far, they all vary in their methodology, their results, the timing of the procedure. Some have been as short as 1 hour, some over 24 hours. The enrollment techniques have been very different. And of course, the primary endpoints have also varied in all of them. Look at them that, on the left, the pink shows some by very short, like 1 hour, when some want to 24 hours. The verdict is one trial along with Tamax, which have been used very extensively in all the meta-analysis and evidence. And it used very early strategy of 12 hours. But this did not reduce the risk of composite endpoint of acute mortality, non-fatal MIs, admission, heart failure, so forth, except for those with a grace score of more than 140. Now that is another, keep this 140 number in mind because it's going to keep on cropping up. And all the trials actually, just to summarize, because I have a feeling that we all go away from a lecture with just one lesson. And so that's the lesson that except for the grace score of more than 140, an early non-STEMI probably doesn't have that much of a benefit. We'll talk more on this. They also did a meta-analysis of 8 randomized control trials, and they all showed no significant mortality reduction. However, the sub-analysis of the high-risk patients was done, and they found that those who had a high risk like diabetes, grace score more than 140, again that number, higher age, they tend to benefit from early revascularization. Tamax was another trial. It was a pretty big trial of over 3,000 people. And that, again, in its 1/3 patients had a score of more than 150 grace score. And they're the people who benefited from early revascularization. And 2/3 had less than 130, 140 score. And they did not show benefit. So when you pull them together, the overall result was not positive. So they thought that this is not a conclusive trial. The sub-analysis showed that there's evidence. So they think it's just a hypothesis-generating trial. It doesn't answer. So there are many other trials, Riddle and the LIPA, and the abroad, and so on and so forth, and ISA Cool. Let me show this. So all of them have been pooled together in this meta-analysis. And you can see that bulk of the evidence is on the side of early revascularization. And the numbers support that too. But they're not, p-value is not significant. So they can't be used as data also. So all the numbers suggest that early intervention has an advantage, but it didn't really match the p-value. The grace score of 140 sub-analysis from Tamac and Verdict, they both pooled together, and they showed that reduction in all-cause mortality associated with the early revascularization in a high baseline risk, again more than 140. And however, these both trials should be taken with some limitations which they had, because when they were being enrolled, they didn't have a very high sensitivity troponin T. They didn't have the potent antiplatelets. They didn't have the guideline-directed medical therapy. So if they were done now, one wonders how useful would they be. So I'm going to rush through some of them now. So rapid STEMI was, non-STEMI was done to clarify this, but unfortunately, it could enroll only 18% of people. And in order to increase that, they included intermediate score people, and they found that the result was again diluted. So one of the conclusions they did was, because I'm rushed to slides because the time's short, that if you want to do a trial which will show early versus late revascularization, you need to enroll at least 70,000 people, which will be so difficult that it's going to be difficult to conduct that trial. So I'm going to rush through some of these trials. We talked about the conclusion of non-STEMI. And so look at the real life scenario. This is 748,000 people's registry where there was a readmission database. And they found that intervention done on the first day had a mortality of 2.4%, and if done on 10th day, it was 6.6%. So real life data is very different and significantly different than what the data shows. Even the 30-day mortality is very significant. So what's happening is that most patients who come have high risk of more than 140, but the European centers do not have the capacity to deal with all of them. In fact, in England, 96%, 94% who present have high 140 gray score, but only 16% were done early. So you need to restructure this whole system in order to cater for them, and can you really cater for them? So one of the conclusions which I think one needs to draw is that the optimal timing is still uncertain, and there's no difference in hard endpoints. Highest baseline is a predictor of future events. Subgroup analysis of the TIMAC and GRACE score suggested more than 40 suggest a reduction in composite ischemic outtime, and there's in early intervention, and there's no extra risk to the patient. Now that's a very important thing, that if you do a very early procedure, non-STEMI, there's no risk involved to the patient. So if there's no risk involved to the patient, there is no definitive early time. So what would be the incentive of doing a non-STEMI early in the admission? If you do it early, the real life data suggests that there is a remarkable advantage in mortality. But what happens is, if you do them early, you get an early bed space. I skipped the data in terms of time. You can reduce 2.5 to 3 days of admission time by doing early procedure. That saves money also. So economically, it's very viable. So if the system can afford structurally to do an early procedure, non-STEMI, it's always a good idea to do an early STEMI because it will create beds for you, save money, and in real life data, registry data suggests it will save life also. Whereas randomized data, which I and Havisa were just discussing, does not show that unless it's a high score. So we need to apply the GRACE score to everybody and follow a lead from there and do it as early as possible. And that varies from one hospital to the other based on the logistics. Thank you very much.
Thank you, sir. I think that was a very elegant talk, as always. Any questions from the audience, please?
I would want comments rather than questions.
Okay, a comment. I think it's very clear that if we intervene early, we are not doing harm. That's what is important. So we need to continue our present practice. We don't need to change it. That as soon as we get a chance of these NSTEMI patients, we should subject them to angiogram and do intervention as needed. And those who are at high risk, they should be given priority. That's it.
Another comment I'd like to make is that non-STEMI is a very misunderstood concept.
You can call it an acute coronary syndrome, you know.
Call it whatever.
Your topic name was NSTEMI, that's why I mentioned.
Sure, of course. Non-STEMI is a very big misconception. Why do I say that? Now, if it is a non-STEMI, we expect it to be an intermittent clot. So why does the LV drop? Why does the non-STEMI drop the left ventricular function? You find so many people, they come with a history of chest pain, going for sometime, they come to you, see some T changes, you say this is non-STEMI. They're actually ST elevation MI which have come late and the ECGs have settled down and you label them as ST because there's no elevation and there's T changes. So they're actually evolving ST elevation MIs and they're still going ongoing chest pain. And there was a very wonderful Korean data that you must apply a door to balloon time on non-ST elevation MI. And his data suggested that if you apply a non-STEMI patients with door to balloon time, you'll be saving very significant lives. So we need to, I think, change terminology from, occlusive MIs to non-occlusive, total wall thickness MI, non-thickness MI. But it's beyond the scope of this lecture to talk about it. But
basically, we have known for decades ECG changes may take up to 24 hours to come up. So, and many of these arteries in end STEMIs are totally occluded, and that's why it's there. And I think you're very right. We need to reevaluate our end STEMIs. How do you do that? I think we'll have to wait and see. But it's very, very significant.
You know,
what you
how
have talked
many
about.
sensible people have tried to devise a trial for it and they could not complete it?
Yeah. Because it's an ECG finding. And ECGs may take a long
It's
time or
very
may never
difficult,
change.
very challenging to put these trials together.
We also have now cardiac biomarkers, you know. We have troponins which give a very early indication that the patient is having problem.
Professor Sohail,
we have some scoring system as well, which are very helpful. In
Yeah, I
deciding.
think grace score, we must apply the grace score, that's very important.
वो बहुत अच्छा है, उससे आपको आइडिया हो जाता है कि आपने इंटरवीन करना है या नहीं करना.
You have defined.
Excuse me, उस दिन आ रहा था कि NICVD के कई centers हैं जो सब saying वो ECG नहीं करते, वो troponin करते हैं. I think that's very sensible. मतलब अगर pain आई है तो troponin is going to dictate something. So ECG of course acute में तो बता देगी.
वो तो बिल्कुल एक अलग चीज है. पेन अगर है तो you have to intervene.
देखिए ECG हम करते हैं उसका तो guideline है कि 10 मिनट के अंदर करनी है. But troponin is the one which has to be done.
Professor Sohail, very nicely presented topic, but I'm still slightly confused.
That makes all of
us. How you clarify and differentiate in a non-ST segment elevation MI patients who are at high risk and who are at low risk, number one. Number two, you said grace score of 140. Okay, but will you point out to some other tests which are very simple and a person over there in emergency can at that time immediately differentiate this is a high risk non-ST and this is a low risk or intermediate risk non-ST, like troponins and BNPs and all other. Please, if you have.
Sir, I'm not being funny, लेकिन अगर वो कहते हैं समुद्र को कूजे में जमा कर दिया ना, तो अगर एक समुद्र कूजे में आ सकता है तो उसको रहना ही इधर चाहिए. It's not a bloody समुद्र, you know. So what I'm saying is कि देखिए जब आप गाइडलाइन को छोड़ देते हैं ना, किताब से हटते हैं तो फिर it's a educated guess. I mean I could not और हाँ फिर अपना आपके logistic system बनाना है ना. अब जैसे होता है कि जी आपने हर ट्रायल में वो अंग्रेज़ों का सिस्टम है, फिर 18 मिनट में अस्पताल से बंदा घर से अस्पताल पहुंच जाता है. यहाँ पे तो 1.5 दिन लग जाता है किसी बंदे को. तो आप जिनको आप स्टेज कर रहे होते हैं, I mean can you leave them alone knowing कि वो 1.5 दिन लगा के फिर 20,000 की गाड़ी करा के आएगा. All those things matter. So जो आप पूछ रहे हैं, I wish I knew what the answer was. I don't even understand the question actually, but
So would like to just ask.
नहीं sir, माफ करना. I'm very serious. I mean it's a very wonderful concept that you're saying, but very.
Sir, just one question, sir. Thank you very much for a wonderful talk, sir. I just wanted to ask that, like you said that the high-risk patient, they should be intervened earlier. So we see many times in hospitals where the primary cath facility is not available. So we have to transfer those patients immediately to the nearest tertiary care setting for those PCIs. But the high-risk patients are those who are having hypotension or they are in failure. So transferring such patients to the nearest cath facility, it's also hazardous, considering the safety of the patient. And then, you know, the staff, they're also, you know, concerned that transferring such serious critical patients to that facility. So what should we do about them? Like, you know, we should transfer them as such, or if we wait, then definitely mortality goes high. But if we transfer them in the same condition, so that transport is also a dilemma. So what's your say on this?
हमारी एम्बुलेंस पे तो ऊपर एक सायरन लगा होता है, एक ड्राइवर होता है, एक ऑक्सीजन सिलेंडर होता है ना. That's not an ambulance. मतलब लेडी डायना का जब हुआ था तो फ्रेड जो एम्बुलेंस आई थी उसमें 4O नेगेटिव ब्लड पड़े हुए थे. एंड जब ये ब्लू लाइन एम्बुलेंस चलती है वो हार्ट शोल्डर पे चलती है. It's as efficient as a intensive care. So जब हमारे पास वो logistics नहीं है तो फिर it's fair game. लेकिन फौज में तो कहते हैं कि बंदा रास्ते में नहीं मरना चाहिए. Let him die where he is. Don't if you send him, he dies. That's it. You're in trouble. So let him die in peace. आपका जो बंदा है ना, rather than the family has to be taken into confidence. पूरा system बनेगा. So this is where Del Kiani and the administrative things will come.
So one more question, sir, please. So one more question, with your
Sir,
permission,
we'll
sir.
take
It was
one last
excellent
question.
academic talk. My question is this: after just having the sense STEMI in front of you, you're just going to opt the early invasive strategy for the coronary angiogram, and most of the STEMI usually present with the more than one vessel disease. So what will be your decision just to go either with your naked eye decision, opting the culprit vessel, or you will just going to opt some other test? And we have to just clarify the answer with our averagely equipped labs in most of our part of our country. Second part of question is this, most of the centers are not been equipped with the low molecular weight heparin. So can we just replace the DOVAX with the heparin with these NSTEMIs, because it's a real fact, the unavailability of the things. So please, your kind comments on this.
देखिए, वेरी गुड क्वेश्चन, लेकिन सबसे अच्छा सवाल किसी ने नहीं पूछा अभी तक। सबसे अच्छा सवाल ये है कि जो गाइडलाइन है वो कहती है कि आप कैथ करने से पहले उसको एंटीप्लेटलेट ना दें, बिकॉज वहां पे जिन्होंने गाइडलाइन बनाई है उनकी सर्जिकल टाइम इतनी तकड़ी है कि वो बंदे को कैथ लैब से उठा के थिएटर में ले जाएंगे। हमारा प्राइमरी पीसीआई में हु इज गोना सेंड समबडी टू द कैथ लैब, फ्रॉम कैथ लैब टू द ओटी? नो वन। सो और हमारे इतने ज़्यादा एडहॉक्स होते हैं कि इनको आप गाइडलाइन फॉलो करें, एंटीप्लेटलेट ना दें, देन सी व्हाट हैपेंस। यू गॉट टू गिव, हम तो दे सकते हैं ना। सो देखिए, गाइडलाइन इज मेड बाय द फंड प्रोवाइडर, जिसने पैसे देने हैं। मसलन फरहान साहब का ड्राइवर आ गया, फरहान साहब कहते हैं मेरा पास चालू कोई नहीं है, लो जी इसको ट्रीट हिम लाइक ए पॉपर, बट वो कहते हैं यार बड़ा खानदानी बंदा है मेरा, इसको कुछ होना नहीं चाहिए, एंड देन थैंक यू फॉर द बिल। लेकिन अब फरहान साहब अगर उसके पैसे सारे दे रहे तो गाइडलाइन चेंज हो रही है। तो गाइडलाइन इज डिक्टेटेड बाय द फंड प्रोवाइडर। सो आई मीन जो अपना लोकल फैसिलिटी है, अगर DHQ फॉर एग्जांपल अगर है, उसमें डिस्प्ले भी नहीं है, तो अब क्या कर सकते हैं? देखिए, डॉक्टर विल ओनली यूज द डिवाइस ही हैज। सो इट इज द सिस्टम, लाइक आई वाजंट जोकिंग व्हेन आई सेड कि मेडिसिन इज सच अ सीरियस बिजनेस, इट कांट बी लेफ्ट टू द डॉक्टर्स। हम लोग तो एक एंड मोटर न्यूरॉन के एंड पाथवे है ना, जो आएगा वो करेंगे। वी विल बी ब्लेम्ड फॉर एवरीथिंग कि हम तो आप, लेकिन प्लीज आप कीप योर हायर अप्स इन पिक्चर। इफ समथिंग गोज रॉन्ग, देयर से आप बताते हम तो इसको अमेरिका भेज देते। आए दिन होता है कि छापा मारा उसने, उसका भी फ्री करा दिया, उसका फ्री कर दिया। व्हाट अबाउट द अदर 80 पीपल लाइंग इन द वार्ड, उनका फ्री कौन करेगा? सो ये वी आर मेड स्केपगोट्स। सो प्लीज लुक आफ्टर योरसेल्फ बेस्ड ऑन ए सिस्टम, या आप किसी बड़े बंदे से जारी लगा के रखें, जैसे सर बैठे हैं वहां पे, जय नजर क्या नहीं, ठीक है। मैंने तो इनके साथ जारी लगा के रखी है, नोबडी कम्स क्लोज टू मी। Yeah, and I get elected in elections also.
Thank you, sir, for your talk.
Aging.
Now I would request the next speaker, Professor Dr. Jabbar Ali, to give talk on complex PCI and high-risk PCI in indicated patients.
In indicated patients.
Indicated.
Assalamu alaikum, everybody. The talk that I am given is complex PCI and complex high-risk indicated intervention. This is a chip. It is relatively a new concept. When PCI was started in early 70s or 80s, only the simple lesion would be done by the interventional cardiologist, and all the complex procedure would be referred to cardiac surgeon. So now the time is for surgery and intervention cardiology to get in the same sandbox. As far as the definition of complex PCI is concerned, there is no consensus, but this is derived from comparability and sensitivity analysis that define is if the lesion is more than multi-vessel PCI, more than 3 lesions, lesion length is more than 60 millimeter stent length, and lesion is more than 30. These are bifurcation CTOs. These are complex PCI. So in the beginning, as I said earlier, so now these patients are increasing, number of CTOs and all the complex PCIs are being done rather than being sent to the surgeon. So what is CHIP? It needs a specialized skills, both skill-wise as well as you have to be cognitively and mentally strong. as the age increases, the number of chip procedure will increase, not only because the age because of the age, but as the age increases, there is more complex lesion, more calcification. Most of the patients are post-CABG, and they are hemodynamically compromised. So the chip component actually consists of it has three components. Patient factors, this is comorbidity, surgical ineligibility. Then complicated heart disease for hemodynamically unstable patients, low EF. Then complex PCI. So all these three components has to be present. So there is, as I mentioned earlier, there was no consensus definition of chip. So they have, proposed different definition of chip. So this was the last, it is by the Japanese group who has proposed this new concept. This is what is definite chip. It consists of the complex PCI. PCI has to be complex. And both patient factor and complicated heart disease has to be present. If both are present, this is a definite chip. If one of them, complex PCI plus one of them, then this is possible chip. The rest are non-chip. So this is the diagram which will help. Patient factors, frailty, active malignancy, liver cirrhosis, hemodialysis, etc. These are the patient factors. Then complicated heart disease, concomitant valvular heart disease, low EF, unstable hemodynamics, and complex PCI, left main, chronic total occlusion, if they need some atherectomies, orbital or rotational. So as we see, the chip, definite chip, this is a small number. Then the possible chip, it is double, but majority of the patients are non-chip. What determines the outcomes? The chip itself determines the outcomes. If you have chip patients, the odd ratio is 2, and others, if the patient is on immune suppressive drugs, unstable hemodynamics, and frailty. These will determine the outcome. Long-term outcomes, as we see, event-free survival. If the patient is definite chip, the long-term outcome is not good. If this possible chip, it is better than definite chip, but still not as non-chip. This is whether we need MCS or not. This was proposed by Italian Society of Interventional Cardiology, and it was being endorsed by Portuguese and Spanish Society. And they recommend that if there is unprotected left main or the Santa score is more than 33, then you can use MCS, basically MPELA. So now I will present a few cases. This was a 63-year-old lady, non-hypertensive, presented to us with unstable angina for 1 week. ECG shows STT changes, echo shows preserved EF. We did her cath. We actually sent her to the surgeon, but the patient flatly and the family refused. As we can see, the osteolyticity is total. There is another lesion in the OM, which is also total. So we took the dual injections to identify the course of the CTO. It was a short CTO, osteal. We could cross it with pilot 200 easily, and we initially dilated with one O balloon. So this was the final result. So this patient, this was complex PCI. There was no patient factors, or there was no adverse hemodynamics. So this was just a complex PCI. This is a 61-year-old lady who was hypertensive, presented with unstable angina. She had past history of MI, ECG show STT changes, echo show EF less than 30. So we did her cath. Again, we sent this patient to CABG, but it was refused. So we planned, I have to rush. So we planned two-stent strategy, DK crush. We follow all these steps. So this was the final. So this patient was a case of possible chip because she has complex PCI, needed 2-stent strategy. It has depressed LV function less than 40. This is a 87-year-old patient. He had MI 1 year back, unstable angina, and had a syncopal attack. STT changes on ECG, echo showed EF of 26%. So this was his baseline angiography. As soon as we saw the patients, we immediately sent the patient to a surgeon. And what the surgeon say, they say medical therapy, but the patient was having continuous chest pain. He was seen by 2 surgeons. So we have to do, we planned him for high-risk PCI. We quickly dilated the left main. Right from the beginning, we took the pilot 200, so we can cross the mid-LED lesion, that was CTO. We dilated sequentially initially with 1 and then 2, and then left main stenting. So his EF after 3 months was increased from 26 to 45 to 50. So this was a case of definite chip, complex PCI, patient factors, as well as complicated heart disease, low EF, frailty, 87-year-old. Otherwise, he was well built. And this is a 50-year-old lady. She was diabetic and had interior wall MIs few days back. And we sent this patient to a surgeon. But surgeon, again, because of low EF, she was refused. We started the procedure under the intra-aortic balloon pump because she had low blood pressure and LV was poor. We were having difficulty to track the stents downward. So we are doing now balloon anchoring. So this was the final, and she's still doing well. LV is almost the same, 35 to 40, but she's doing well. She can do our health. This is a case of definite shift. One last case. This was a 100-year-old. He had interior wall MI some year back, and then was having unstable angina and non-sustained VT. So otherwise, he was well built.
Jabbar, 1 minute left.
Okay, just few slides. So this was his cath baseline angiogram, left main. We did a quick mini crush. So this was again a case of definite chip. So this was the slides that I took from, there was a conference in Korea, Complex Intervention 2023. Operator volume dictates the outcomes. If you have high volume operator, the complex PCI outcome is good. This was the question which was asked, IVUS versus OCT, DK crush or DK culottes. The best outcome which was seen if you are planning left main PCI was the operator volume. So take home message, KISS principle, keep it simple. If you, because sometimes the lesion is angiographically severe, if you do IFR, FFR, it may not be that significant. Don't beat your head against the wall dealing with calcium or CTOs, so you should have the right tools available. Maximize success. It means, for example, sometimes we can do it from radial, but it may be difficult from radial or with 6 French cats, so you have to be, don't beat your head. You can change the catheter to 7 French or you change the axis to femoral. Don't be a hero. This is very important. When we are resident, Professor Hafiz would say कि आप अकेले कैथ लैब में जो है जब तक 2 बंदे ना हो PCI ना करें. So it is very true for the complex PCI, the chip procedure, and it has been proven from data. Single-handedly done, mortality was high, complications were high. If there were 2 eyes and 2 brain, the outcomes were good. So if you need MCS, do use it, because God does not think I am an intervention cardiologist. Thank you very much.
Thank you, Jabbar sir, for some very good case and a great presentation. Floor is open for any comments from the panel or from the audience.
Excellent talk. I think we need to assess these patients, the patient and the lesion. If the patient is low risk and the lesion is low risk, then anybody can attempt it. Then there are patients who are high risk and the lesion is high risk. They should be done under supervision with an expert operator. Then the third, which is the definitive chip, high risk lesions in high risk patients, they should only be done at big centers with operators having very high volume, because it does matter.
Yes, sir. You are very right. So this concept was actually started in 2016 by Dr. Dusi, and they have a white paper in circulation. The reason behind, because we do see in our clinical practice, patients, angio is done. For example, once I saw a patient, 93-year-old, angio was done, and then he was advised CABG. So surgeon would not touch the patients. So you have to assess the patients first, whether, because sometimes malignancy, life expectancy is less, very low, 6 months or less than 6 months. So we don't have to be a hero in such a cases. But if otherwise indicated, we have to do something and give some hope for to these patients.
And secondly, you showed that IABP doesn't have mortality benefit, but recently the danger trial has, that was on the microaxial pump. It did demonstrate the patient can benefit from these pumps in cardiogenic shock. But the only thing was that they had a longer follow-up, about 180 days, as compared with the previous trials where the follow-up was limited about 30-40 days.
Sir, you are very right. The danger shock trial, but actually it was done on STEMI patient, while in CHIP, the patient or either chronic coronary syndrome patient that Mansoor Saab presented, or they are NSTEMI, high-risk NSTEMI. So STEMI and shock patient were excluded from whatever data we have on CHIP.
These tests can be generalized.
Yeah.
So I'm a cardiac surgeon. I just want to, I really don't want to take all the responsibilities that surgeon will not go and touch the patient and something like. I think the only contraindication of cardiac surgery is that if the patient don't wish to proceed for open heart or a major surgical intervention. It is a good concept. If we can give benefit to the patient, it should be proceeded. But I don't think so any surgeon is going to say no. We always welcome. The only thing is that the patient wish will be the first to entertain. If they are willing to proceed for open heart or they are proceed for intervention in cardiology, it is the choice of the patient, not the surgeon. I think the patient will be more to choose what treatment modality should be good for him or her. I don't think so. Surgeons will always welcome. The number of the interventions you show, they all can be very easily accommodated by a surgeon. I don't think so there is any contraindication of surgery. I think it is the patient choice to proceed for his or her. I don't think so. It is the...
You are absolutely right. जितने पेशेंट ये जो 4-5 केसेस मैंने दिखाए हैं, it was referred to surgeon. And अगर मैं आपको वो it was unethical कि वो जो surgeons के remarks उस पे लिखे थे कि medical therapy.
Jabbar Sahab, we should keep it very scientific, this discussion. Na? Okay, this is not a patient's choice anymore. It's like a shared decision making.
Yes.
आपने patient को educate करना है, उसका नफा नुकसान समझाना है, and then you're gonna help him decide. And देखिए, there's an awesome trial, almost 10 years old. उस वक्त angioplasty बहुत primitive थी. They took all those high-risk patients for surgery and they did surgery with angioplasty and they found that surgical limb had a better outcome. So देखिए ये कहना कि surgeon would never say no, that's very noble, we say respect that. But देखिए आपने आखिर में ये नहीं करना कि दिल चला दिया, बाकी सिस्टम का क्या होगा? We are responsible for the kidney, the outcome, the lung, the hospital stay, and it is not just the destiny, it is the journey which is also important. You have to have a smooth.
Take the patient with us.
Yeah. So talk about. It's scores. Just follow the scores. And I must tell Nasir बैठे कि जब इतना बड़ा सिस्टम होता है जैसे FIC है with so many patients, तो आप लोग अपना खुद स्कोर बना सकते हैं.
So the patient
Which would be
preference come
effective for
first.
that when you know the predictors of bad outcome. आपके पास सर्जिकल एक पूरा डेटाबेस है, उसमें आप correlate करें with bad outcome.
Sir, it's our duty to inform each and everything. We have
So
to
आप-
talk about the predictors and everything,
मैं
but the
आपसे-
patient preference will come at the first, as
मैं
according to
आपको-
the guidelines.
जी,
Yes,
sure.
sir.
मैं कह रहा हूँ कि आपको इतना बड़ा डेटाबेस है, आप उसमें से predictors निकाल के you can make your own score. So you have to be very scientific about this decision.
So I think it's a great discussion and can go on. We will call it a day today and we'll move on.
Thank you very much.
And now the request is to the panelists and to the audience that keep question answer session for at the end of the session. As we are running short of time, the next speaker is Dr. Chirag Hussain, and he will give a talk on reperfusion management strategies in STEMI.
ये स्लाइड यहाँ से होती है, ठीक. बिस्मिल्लाहिर्रहमानिर्रहीम. Respected panelists and dear colleagues, अस्सलाम वालेकुम. पहले तो मैं एक रिक्वेस्ट पहले से ही कर देता हूँ कि ये जो मेरा टॉपिक है बहुत ही इम्पोर्टेंट है. ये बहुत कम मेडिसिन में इंटरवेंशन है जो आपकी मोर्टेलिटी 50% रिड्यूस करती हैं, लेकिन यही है जो मैं आगे डिस्कस कर रहा हूँ. 50% मोर्टेलिटी रिडक्शन है इस स्ट्रेटजी के साथ, तो बाकी हैं लेकिन अभी तक डॉक्यूमेंट नहीं हुए जो मोर्टेलिटी रिडक्शन है अगर हम कॉम्प्लेक्स PCI करते हैं या और रूटीन इलेक्टिव PCI करते हैं. तो ये एक रिक्वेस्ट है, अगर 2-3 मिनट ज़्यादा हो जाए तो ये बिल ज़रा कम बजाइएगा. तो 1 मिनट तो बहुत ज़्यादा है ना सर. 3 दे दे सर, 3 दे दे, खैर है कोई बात. अब मैं शुरू कर देता हूँ. तो माय टॉपिक इज reperfusion strategy and ST elevation myocardial infarction. I will be talking about this topic under these 3 headings: reperfusion timeline, when to give thrombolytic and transfer patient to PCI capable center, how to combine thrombolytic and PCI, which is also called pharmaco-invasive strategy. So this is just new LVB is overwhelming sign of chronic cardiomyopathy, ischemic or non-ischemic with a dilated or hypertrophied myocardium rather than an extensive acute infarction. That's why in 2020, European and American guideline is no longer considered LVB as equivalent to acute ST elevation myocardial infarction. So this is very important slide. The first hour of the presentation of acute ST elevation MI is called a golden hour. Golden hour thrombolytic are very effective for fresh thrombus. In the first hour, almost thrombolysis is almost equal to the primary PCI. 1 to 3 hour is still a good time zone, and you can save good percentage of myocardium in this time zone. Thrombolysis are still effective. 3 to 12 hours, most of the necrosis has already been occurred. Thrombolysis are less effective, PCI much more effective. And reperfusion therapy in this time period actually treat peri-infarct angina, reduces the adverse left ventricular remodeling and decrease the mortality. May save some myocardium, mainly if pre-infarct angina or if artery partially recanalized or they have pre-existing collaterals. 12 to 24 hour thrombolytic are ineffective, PCI is somewhat effective. What is the patency rate of thrombolysis? TV2 to 3 flow can be achieved in 70 to 75% of these cases, and even more than 90% if they present in the first hour. There is some adverse effect of thrombolytic, most common is intracranial bleed, that occur in about 1% of these cases, and 15 to 30% of those who thrombolize have recurrent MI or recurrent myocardial ischemia. The superiority of PCI over fibrinolysis widen as the presentation is more delay beyond 3 hours. And that has been shown in this graph. If you see, the result is almost equal of thrombolysis in primary PCI in the first 3 hours, but beyond 3 hours, there is a drop, a drastic drop in the fibrinolytic therapy benefit, while the benefit of primary PCI beyond 3 hours is gradually decreased. Superiority of PCI over fibrinolysis widen. Emergent reperfusion with PCI or fibrinolysis. That's very important. Presentation within 12 hours of symptom onset or up to 24 hours for PCI, but up to 48 hours according to the ECC. If there is a persistent ST elevation in more than 2 or 2 contiguous lead, or if there is ST depression that is isolated, or if there is more prominent NV1 to V3, so PCI or thrombolysis are class 1 indication in the first 12 hours, and beyond 12 hours, PCI is class 2A indication in these patients according to the ECC, and class 1 indication according to the EAC. This apply even if chest pain has been resolved as long as the STs are up beyond the cut point or more than less than 24 hours. PCI preferred if the door to balloon time is less than 90 minutes for the patient who are presenting to the PCI capable center. And if the door to balloon time should be less than 120 if patient is presenting to PCI non-capable center. Patient presenting more than 24 hours and more than 48 hours according to the EAC after symptom onset generally do not have an indication for angioplasty. That is on the basis of occluded artery trial. That trial was published back in 2008, but still is respected because of its design and its result. Emergent PCI is still indicated in these patients who presented more than 24 hours if they have persistent ischemic symptom, or if they have cardiogenic shock, or if they have heart failure, or if the onset of symptom is not clear. So you may do PCI in these patients. When to give fibrinolytic to STEMI patient presenting to non-PCI hospital who are getting transferred to PCI center. 3 minutes रहते हैं, बहुत कम रह गए. अच्छा, primary PCI superior to LATIC according to these trials started from late mid-90s, that is PAMI, DYNAMI, and meta-analysis of 23 randomized trials have documented the efficacy of primary PCI, superiority of primary PCI over the fibrinolytic therapy. However, this depends upon the door to balloon time. If door to balloon time less than 120 PCI, if door to balloon time more than 120, consider thrombolytic mainly if the patient is less than 3 hours, and also consider the factor which argue against the LATIC therapy. That is, if STEMI presentation is more than 3 hours, low risk patient, high risk patient is those who are anterior MI, those who have cardiac failure, and if age is more than 75-year age. And if the ECG changes are subtle, just ST elevation which are just fulfilling the criteria for MI, they should have reperfusion must. First hour is golden hour for LATIC that reduces the mortality 50% in this patient. In 1 to 3 hour, 30 to 40% reduction in mortality. Time of presentation less than 2 to 3 hours make LATIC comparable option to primary PCI as it is very effective in analyzing thrombus. Uski tension hai mada time ki. Thrombus as that have been documented in PRAC2, CAPTAM, STREAM trial. These the trials which have documented that if presenter is earlier, then the result will be almost equal. STREAM trial, not go into the detail of this trial. STREAM may be seen as a LATIC success in those who present as door to balloon was still decent. That is the sub-study of Horizon and Cadillac. They documented that if the door to balloon time is more than 90, that worsen the situation, worsen the outcome, especially in those who are early presenter, less than 1.5 hour, but not in late presenter. For patient presenting with more than 3 hours, or if they are high risk, do not accept any delay and keep in mind the effectiveness of lytic in this time period. Give thrombolytic and transfer for PCI. For presenter more than 3 hours in low risk, this against the lytic, transfer for PCI. But these are a few contraindications, you all know about that, but I will just mention the most important, that is if they have a ischemic stroke within 3 months, except if they have acute stroke within 4.5 hours. Unresponsive, uncontrolled hypertension in those who have surgery within 3 hours, within 3 weeks, or internal bleed within 3 to 4 weeks, and oral anticoagulants. Once you have decided to give fibrinolytic therapy because of expected delay, when do you do PCI after fibrinolysis? That is a two types. Rescue PCI है, अगर failed thrombolytic therapy है, a patient develop cardiogenic shock, heart failure, rescue PCI regardless of the onset of the time since onset. And routine early PCI is also called pharmacoinvasive therapy. The pharmacoinvasive strategy, 2 to 24 hours of thrombolysis was associated with decreased recurrent MI and similar outcome to a timely primary PCI. And PCI so soon after lytic is safe with no increase in major or moderate bleeding risk. Why? Because of the short pharmacokinetic and short pharmacodynamic effect of thrombin-specific thrombolytic, which unfortunately, at least मेरे सूबे में तो उसकी अवेलेबिलिटी बहुत कम है और इसकी इफेक्ट यह है कि they will affect just plasminogen present in the thrombus, which they convert into plasmin, which then degrade the thrombus bound fibrin. And these are the various available thrombolytic agent, and we just have streptokinase rarely. Before transfer, all patients should receive aspirin, clopidogrel 300 milligram, not 600 milligram, within the 24 hour of lytic therapy. टाइम खत्म है वरना ये केसेस में प्रेजेंट करता है. चलो आप पूछें उसके बारे में आगे बात करते हैं. थैंक यू जी. इम्पोर्टेंट है, पूछें. वो मैं फिर कहता हूँ अगर सर इजाजत हो तो सर वो मैं अभी एक
So we are running short of time by 50 minutes.
सर एक जवाहर साहब.
So we have the panel has decided there are no questions and no comments. We just have the lectures.
Sir, just
okay for your sake only.
जवाहर साहब अभी इसने पेशेंट प्रेजेंट किया है, वो शायद मैं अगर मैं गलत नहीं हूँ तो वो कह रहा था कि 2 days पहले इसको MI हुआ था और वो जवाहर अली उसको इंटरवीन कर रहे थे. So before 48 hours, after 48 hours according to EAC and after 24 hours according to the ACC, this intervention in angioplasty is not recommended if there is no chest pain, if they are not in heart failure, if they are not in. So, but even that is for those because they are using fibrin specific thrombolytic. We are using streptokinase. And streptokinase half-life is about 36 hours. And thrombin-specific thrombolytic, उसकी half-life less than 2 hours है. वो तो studies उसी पे हुए हैं. अगर हम अपने environment में study करें तो शायद हम तो 1 हफ्ते में भी recommend न कर लें. तो ये बताना था. Thank you.
Thank you.
Thank you, sir, for your talk. The next speaker is Professor Dr. Akhtar Ali Bandesha, and he would give a talk on CTO PCI.
Bismillahirrahmanirrahim. My topic is CTO. Actually, it comes under the umbrella of CHIP most of the time. And as the discussion was being done in a previous talk, that the surgeons, they like to do complex surgeries as well. The volume of the patients is so much
that the current number of surgeons, probably they cannot handle every patient who is destined for surgery, because in every hospital, at least 30, 40, 50 patients are being angiography daily in major centers, and how many surgeons are there who can operate upon at least 50% or 30% of them. So the complex angioplasties, they will remain there. CTOs, they are diagnosed in around 16 to 20% patients with coronary artery disease undergoing angiography, and the procedure volume has increased from 2.7% in 2010 to 4.5% in 2017. So, and the success rate is also increasing with the passage of time, with newer techniques and technologies available for the CTO. The main indication of CTO PCA is symptom relief. Meticulous pre-procedural planning and systematic crossing attempts are recommended to optimize CTO PCA success rates. Intravascular imaging can facilitate CTO recanalization and improve long-term outcomes according to the newer guidelines. A systematic approach to complications can minimize their adverse effects. So basically, I will be talking about these three things in next few slides. How can we plan a CTO? How can newer devices like IVUS and every other devices, they can help in more success in the CTO intervention? And how can we minimize the complications associated with the CTO intervention? So, meticulous planning, look at the angiogram, look at the prior films as well. If CT angiography is available, that will also help you in planning what strategy and what type of procedure you will be going with this. And this will result in less contrast and radiation and less fatigue to the patient and operator both. And we must check the viability and ischemia both, so that we must know before we embark upon that are we giving any benefit to patients or not. And time to talk with the patient and family, this because it's a complex procedure, so it should be discussed in detail with the patient and his or her family, because of the procedure cost, the complications associated with the failure associated with, and all those things. So if they know from day one that this is a complex procedure, the things will be easier for the operator and the team. So study the lesion. We all know that proximal vessel tortuosity which would make things more complex. So is it tortuous or not? The proximal cap is ambiguous or clear. It is tapered or blunt. Side branches are there or not, and how much calcification proximally as well as in the lesion is there. Study the lesion segment, CTO segment length, how much it is, the segment calcification, that will also determine how the things are difficult for the procedure. And how about the artery after the CTO, the caliber and quality of the distal vessel, is there any bifurcation or not? Is there any prior bypass graft insertion site or not? We must be looking all these things. Quality of the collaterals, it's also important. What type of, we all know that which collaterals they are preferred, the bypass graft first one, and then septal, and then epicardial. So what is their size and all that? And are they tortuous or not? How much dominant they are, their angle and location at the anti-side, it's also important, so that you may assume whether your wire with the retrograde approach will be going into this into the main vessel on which side. So this is Warner classification. I will not be going into the details. JSCTO score we all know, and the less the JSCTO score, the more successful the wiring is. So it's important. So this is another CTO score. and this will also will help you in determining how much difficult this case will be for you. And anticoagulation during the PCI, if it is antegrade approach, more than 60 seconds actually, and if it is retrograde, then 350 should be the target. Double axis and dual injection, low magnification should be used. Inject donor vessel first, wait 1 to 2 seconds before injecting CTO vessel. No panic should be done while you are giving injections, and cine until the contrast clears. So that will help you in seeing clearly the proximal as well as the distal vessel. And the different wiring strategies, they are antegrade wiring and retrograde wiring. Integrate, they are simple, and then dissection and re-entry and retrograde is also like that. This is a hybrid CTO crossing algorithm where you must see with the dual injection whether there is a ambiguous proximal cap or not, poor distal target or not, appropriate interventional collaterals are there or not, and if it all are there, then retrograde approach is preferred. If it is not like that, the antegrade approach will be preferred. And if lesion length is less than 20 millimeter, then antegrade wiring is preferred. And if it is more than that, then antegrade dissection and re-entry is preferred. And then different catheters you can use, control stingray catheters or wire-based loss strategy like that. And if retrograde approach, then retrograde through lumen puncture or retrograde dissection and re-entry accordingly. This is another Asia Pacific Society algorithm where they use this IVUS guided. Actually, the rest of the things they are as they are with the previous system, but they use IVUS to see the lesion and help in CTO. Wire selection and escalation start with polymer jacketed wire with soft tip like Fielder XT or Fighter, and then you can proceed to Gaia second or Pilot 200, and then proceed to stiffer wires like in Confianza or Hornet, all those. Methods for solving proximal cap ambiguity: IVUS guided entry of proximal cap, move the cap techniques, antegrade, dissection and re-entry, retrograde approaches. These are different things with you can solve the proximal cap ambiguity. Move the cap techniques, power knuckle technique, balloon assisted subintimal entry base technique, or side base technique, or dual lumen microcatheter, and all those. So these are different types of techniques which you can use in CTO handling. And this is about the power knuckle, where a balloon is being used to fix the microcatheter so that you can apply more force on the wire and can cross the lesion. And balloon assisted base technique, actually, here you are using the balloon. And side balloon technique, in a side branch, actually, you are using the balloon and trying to make the procedure more successful. And dual lumen microcatheter, you can use one for the wire and one for the balloon, or the second wire in the side branch. And then the Corlino method, which you give injections, small volume of injection, contacts, and you can see you can go into the proper channel. Scratch and go technique, these are different techniques. Antegrader wire escalation, true lumen crossing, subintimal crossing or exit and all that. And retrograde approaches, we just touched it. And this is updated algorithm, which is similar. It's very, you can read it actually yourself. And role of IVUS, I'm not going to go into its detail, but it is being used and it's a good thing. IVUS guided puncture in case of proximal cap,
evaluation intraplaque, and I will not be the complications. There are number of complications. I will not go into details, but we can reduce these complications. Thank you very much.
Sir, thank you for your talk. Next talk is on left main PCI in Pakistan. It would be given by Professor Dr. Nasir Samol.
Bismillah ar-Rahman ar-Rahim. I'll be discussing left main stem PCI evidence and practice. Now, left main stem disease is found to be in 3 to 5% of patients undergoing coronary angiography. And patients with LMS disease have a high morbidity and mortality because of the large myocardium at risk. Most of the patients of LMS disease are treated with cabbage. Syntax trial subgroup analysis showed the PCI is a viable option in left main stem disease patients. Now, this is the percentage distribution of involvement of different parts of the left main stem, and it is most common at the bifurcation, which is 66%. Now, bifurcation lesions are divided into true bifurcation and non-true bifurcation, depending upon whether the main, proximal main and the side branch have more than 50% stenosis or not. These are various different classifications which you all know very well. And Medina classification is the most commonly used classification, and in Medina classification, as you know, a number is assigned to, number 0 or 1 is assigned to lesions. If it is more than 50%, it is 1. If it is less than 50%, that is 0. And broadly, there are 2 bifurcation strategies, as has already been discussed: provisional and two-strand strategy. And these are the various two-strand strategies which you are well aware of. According to the Syntax trial, cabbage resulted in a fewer major CV events compared with PCI among patients with triple vessel coronary artery disease or left main stem disease. The Syntax trial, the scoring has been divided into 3 groups, which is low syntax, intermediate, and high syntax score. And the cutoff is 22, 23 to 32, and more than 33. This was a trial, Recombat trial, which showed that at 10 years, there was no significant difference in MACE between 2 groups, which was cabbage versus left main stem PCI, although the risk of repeat procedures was more in case of PCI group. The Excel trial, which is a landmark trial, it showed that the left main coronary artery disease patients with low or intermediate syntax, they are good for PCI. And again, there was more incidence of revascularization in the PCI group. And this is, again, the outcome of the Excel. Similarly, Noble trial, another landmark trial, in which there was a composite of all-cause mortality in repeat coronary revascularization with stroke, and occurred in 29% patients treated with PCI and 19% patients treated with cabbage. These are the different meta-analyses which had been done from 2009 to 2021. and various different trials have been done in patients with high-risk anatomy with LMS disease and multivessel disease. CABG is, of course, has the clear advantage. The patients with low or intermediate syntax score, they can be taken for PCI. This is the definition of complex bifurcation criteria. There are major and minor criteria, and there are two major. If the lesion is more than 10 millimeter and the stenosis is more than 70% in case of left main stem, and more than 90% in case of non-left main stem disease. A complex bifurcation is defined as either two major or one major and two minor criteria. These are the various trials which have compared the provisional versus two-strand strategy, excluding the last one, which is Nordic 2. And in almost all these trials, the provisional strategy showed better outcome. These are few more trials comparing provisional versus two-strand strategy, and they have been done till 2021. Now, there are certain features which favor provisional strategy, which are, for example, small-sized circumflex, insignificant disease at the ostium of the circumflex, small length of the lesion of the circumflex at the ostium, right dominant system, and a wide angle between LAD and the circumflex. Now I'll present a case, a 76-year-old gentleman, Canadian fidelity class 5, hypertensive, smoker, labs unremarkable, presented with non-ST elevation MI. And this was his angiogram. This shows disease at the distal end of the left main, including the osteoproximal LAD as well as circumflex. And you can see the various views. The right coronary artery is essentially normal. There is no critical disease. His syntax score was 26. And as far as syntax 2 is concerned, there was a PCI, 4-year mortality for PCI was 14%, and 4-year mortality for CABG was 20%. And his Euro score was 10.19%. And here's the indication for the use of intravascular imaging, which is IVUS. It is class 2A indication. Now, IVUS helps us in making the decision about the luminal size, the plaque distribution, plaque characterization, stent sizing, and the length of the disease. So it is a very helpful modality, and I think everybody believes that it should be used in all left main stem PCI. Heart team meeting was done. Actually, patient was advised CABG, but the patient family were counseled thoroughly for that the CABG is a superior option. However, they declined CABG and they opted for a PCI. And a 7 French sheathless guide catheter was taken, and both LAD and circumflex were wired. LAD was pre-dilated with 315 balloon, and circumflex with 2.75 NC balloon, and left main stem with 3.5 12 NC. IVUS was done in both LAD as well as circumflex, and these are the runs of IVUS. So you can see a lot of atheroma, critical disease, and some calcium. So we proceeded with the procedure, and we stented, we parked a balloon in the LAD and placed the stent in left main to circumflex, deployed that, and crushed with that 3.5 12 NC balloon. And then step crush was done with 4.58. I will go through quickly as the bell has rung. And dot was done. We did, this was basically DK crush technique, and we did all the steps. And I'll be quickly going through these steps. So this was the standing of the LED. This was pot done with 508 NC balloon, recrossing and opening the studs. And this was the final result. Final IVUS run was done, and final pot again was done with 508 balloon. And that was the final result. Recovery was uneventful, patient stayed well, there was no complication, and he was discharged next day. This is the data of FIC. In 2023, we did 123 cases of left main stem PCI, and 93 cases were done with provisional strategy, whereas 27 cases were done with DK crush technique, and 3 cases were done with other techniques. And on the right side is total number 42, and then DK crush 28, and other techniques 13, and that is the data of this year till June. Thank you very much.
Thank you, sir, for your talk. Next speaker is Professor Dr. Sher Bahadur, and he will give a talk on bifurcation PCI, procedural techniques, steps of different techniques.
Bismillahirrahmanirrahim. I am thankful to the organizer for inviting me for this talk. I will talk on the procedural strips and bifurcation techniques. You know that the true bifurcation is the one which the side branch has more than 50% disease and the side branch has more than 2.5 millimeter in diameter. You know the definition criteria. Based on this criteria, we divide the true bifurcation into simple true and complex true. The reason is, if there is simple true, we go for provisional stenting, and a complex true, then we go for upfront two-stent strategy. There are trial, very famous Nordic, Cactus and BBC one, which showed that the provisional strategy is the same as that of the plain two-stent strategy, but these were the old trial, and those era, the stent, the drug-eluting stent was the first generation, and in these trial, the true bifurcation was not deal. The non-true bifurcation, yes, it is true. Evidence is cross-Korean trial in Nordic that they leave it alone strategy, that don't touch the side branch. The output was the same with provisional stenting. And other trial for the true bifurcation like Perfect and Lipman trial, EBC, MAN, DK Crush, they proved that the two-stent strategy is the same as provisional stenting. But again, these trials were not including the complex true bifurcation. The complex true bifurcation were included in the definition 2 trial and DK Crush trial, DK Crush 5 complex group, and they proved that the two-stent strategy is better than the single-stent strategy. Coming to the steps, and bifurcations part is the important step because we select the stent according to the distal main vessels. So the proximal vessel is undersized to approximate it. We do port. It reduce the accidental abluminal wiring as well as it open the strut at the ostium of the side branch, so rewiring is easy. We should know the predictor of losing of a side branch and these bifurcation PCI. So if the bifurcation core stenosis is more, or the ostium of the side branch stenosis is more, or the ratio between the main vessel and the side branch is more than 2, or if there is a less than T3 before putting a stents, then it means losing of a side branch is high. For rewiring, we should take help of the pre-shaped wire, dual lumen microcatheter, angle microcatheters, deflectable microcatheters, and bifurcation. There is nowadays very famous JSKBT. The various modification is available. The gel balloon, balloon stent kissing, semi-inflated balloon, semi-inflated kissing balloon technique. So to start the step, if there is a simple two bifurcation, we should start with the provisional stenting. The steps are wire both branches and stent the main vessel to a port. If the result is ideal, the procedure is ended. If there is dissection and the side branch is less than T3 flow or the ostium of the side branch is stenosed, then we should go further step. We criss-cross the wires and do the KBI, kissing balloon inflation, followed by a port. If the result is optimal, the procedure will end. If there is indication for stenting of the side branch, then we should keep this algorithm in mind. So if the side branch is having 90 degree, then we should go for T-stenting. If the angle is 90 to 70, then tape technique. And if the angle is less than 70, then Coulard technique. But if the side branch and main vessel are not equal in diameter, then we should go for internal crush or reverse crush. And if we are unable to cross to the side branch, then we can crush the proximal main vessel still and can do the inverted DK crush. If we are going for the upfront two-stent strategy, then the same, but here we will start from the side branch. So the names are inverted Coulard, inverted tape, and inverted T, and the DK crush. So just if the provisional stenting, there is an indication for stenting of the side branch. If the angle is 90, we will put the stent at the ostium of the side branch, and then we'll balloon with nominal pressure, then we'll remove balloon proximally, and we'll go with high pressure. This is to optimize the ostium of the side branch. Then we'll do KBI, and then port, and the procedure will end. In case we put the side branch stent to distally, so we will cover with a third stent, and if we put the stent to proximally, then we will convert into the Coulard technique. And suppose 1 to 2 millimeter is in the proximal vessel, so internal crush will occur, and then we will proceed with the internal crush. The same technique is in the T-stenting, but here if the angle is less than 90 and more than 70, so we will go with the tape. So we have already done the main vessel, and we will stent the side branch with the tape. Tape means we will protrude the ostium of the stent and the side branch 1 to 2 millimeter in the main vessels. Just concentrate on this. There was importance of KBI, that is kissing balloon inflations. If there is no kiss, just see the MHA. This is what the stent looks like at the ostium of the side branch. When the first kiss was introduced in the classical crush, then this is what the ostium of the side branch looked like. When two kiss was done in the DK crush, then the ostium of the side branch is very clear, so the struts are away from the carina. So that's why this double kissing was incorporated in the technique, that is DK crush, DK Coulard, and DKT. That is the balloon assisted double kissing T technique. So coming to the inverted Coulard. Inverted Coulard, we will start from the side branch, and after putting a stent in the side branch, we will do a port. After port, we will wire this stent again, and then we will put a stent in the main vessels and will dilate it, followed by a port. After port, we will do KBI and port again, and so the procedure will end. Coming to the DK crush, the first stent. So we will wire both branches, then pre-dilatation of both branches, then ballooning, then we will put a stent in the side branch. Here the protrusion will be just 2 millimeters into the main vessel. Then we will crush this with a balloon. This balloon size should be according to the distal main vessels. If this is incomplete crush, then we will take a balloon according to the proximal main vessels, and after crushing, we will wire the side branch again with and then small balloon, then a large balloon, and then we will do KBI. So coming to the balloon assisted DK T stenting, this is the same like T stenting, but here While putting a stent in the side branch, we will take help of a balloon. Balloon is inflated for optimal positioning of the side branch stents. Then stent is deployed and the balloon is deflated again. After this, we will do KBI, and after KBI, we will pass a stent in the main vessels, and with the help of a balloon which is already there in the side branch, then we will do a port, KBI, followed by a port. It is the same like balloon-assisted DKT stenting, but if the angle is narrow, we have to put the side branch stent 1 to 2 millimeter in the main vessel. The remaining steps are the same. Coming to the crush technique, initially concentrate on the first line. Initially there was a classic crush in which you have to protrude your stent and the main vessel 4 to 5 millimeter. So position the side branch stent and the main vessel stent, then deploy the stent in the side branch and crush it with the stent and the main vessels. So the outcome was not good, so that a kiss was added, that is KBI was added. So the classic crush with the KBI is the same like classic crush, but here the KBI was added. Then there was a problem crossing the side branch wire into a side branch. So the mini crush technique was emerged, and again it is with the 7-port guiding catheters. So here the steps are the same like classic crush with KBI, but before KBI there was a port. So in the remaining technique there was a port, kiss, port. The reason is you have to do port to cross a wire into a side branch, and then after KBI there is a proximal stent deformation, so to correct that you will do port again. The mini crush technique, the 6-French guiding is the same like mini crush with 7 French, but here instead of stent and the main vessel you will put a balloon for crushing. The remaining steps are the same. The decay crush I already described. There are 2 kisses. First kiss after crushing of the stent and the last port, kiss port. The nano crush is the same like mini crush, but here you will protrude the side branch stent 0.5 to 1 millimeter. This slide shows that among all these techniques, the decay crush was proved to be superior over classic crush. It is proved in the decay crush 1 trial, and the remaining all mentioned trial, the decay crush proved to be superior over provisional T stenting, Coulard, and provisional stenting. This is why the decay crush was considered to be the class 2B indication. It was preferred with the T stenting technique in case of LMS. This slide shows that the 2 stent techniques are superior over 1 stent technique, but in this definition 2 trial and major. This is the last slide.
Okay, thank you.
Okay, so and the majority and the 78% of the cases the decay crush was used. Okay, thank you.
Thank you so much. Thank you.
Thank you, sir, for your talk. Now, the next talk would be given by Professor Dr. Asim Javed on role of mechanical thrombectomy in pulmonary embolism.
Bismillah ar-Rahman ar-Rahim. So we're going to switch gears. I know I'm the last man standing between you and the lunch, but I think I take this opportunity as we've got all the leaders in interventional cardiology sitting here, all the heads of institutes, and I think this is a subject that we really need to focus on. The reason being, we all know that pulmonary embolism is the 3rd commonest cause of death in cardiovascular deaths after STEMI, acute stroke, and 3rd one is pulmonary embolism. And the paradigm is really shifting in how to treat these patients. I'm going to skip a few slides and skip a few statistics in the interest of time. So I'm sure we all have experienced the same situation in the ICU where we have high risk or intermediate high risk pulmonary embolism patients, and we treat them with lytics, we give them anticoagulation, and what next? So we are waiting for these patients, and it's frustrating. We don't have anything else to offer to these patients. But as I said, the paradigm has changed. We are good at reducing mortality. So the mortality of TEVI has come down to less than 1%. Mortality of STEMI without cardiogenic shock is less than 1%. Mortality of high-risk pulmonary embolism is still 63%. We all know how to define intermediate high. So if we have 3 criteria, one is the blood pressure. If that is low, if the cardiac biomarkers are raised and RV dysfunction is there, it's a high-risk PE. If the blood pressure is still stable and the other 2 are abnormal, then it's a intermediate to high-risk patient. We've got scoring systems, we've got PESI score. Most of us see these patients in PESI score 4 or 5, and we know that their mortality is around 25%. Another way of looking at these patients, this is BOVA score. So if the patient has a blood pressure of more than 100 millimeters systolic, but he has RV dysfunction, he has raised biomarkers, he has tachycardia, the mortality at 30 days goes up to 42%. It's not only about mortality with pulmonary embolism. Even if we help these patients to survive the initial phase, they still have chronic sequelae in the form of persistent dyspnea, syncopes, dizziness. They have permanent problems going on. So why do we need new treatment options in pulmonary embolism? Because we need to reduce their mortality, which is still very high. High-risk PE, mortality is 63%. Intermediate high-risk patients, mortality is around 25%. And we need to reduce their morbidity, which are the long-term sequelae. So just to give you a case that I've taken from the West, just to show how things are being managed there, 67-year-old gentleman with 12 hours history of worsening dyspnea. He had adenocarcinoma, operated, and was on chemotherapy. Heart rate is up, blood pressure is still stable. Saturations are down, respiratory rate is up. He's got the typical ECG pattern, typical severe overload of the right ventricle on echo. He's got a saddle embolus sitting in the pulmonary artery, bilateral emboli. RV is enlarged. He has a PESI score of 2, and he's intermediate high risk because his blood pressure is still stable. So as per guidelines, you can give him latex, you can give him anticoagulation. The patient did not improve despite of 12 hours of treatment. Important thing is his blood pressure is still normal, but his lactate levels were going up. So if the lactate levels are going up, that's a very bad prognostic sign, even if the blood pressure is normal. They took the patient to the cath lab, did pulmonary embolectomy, and there was immediate response. You can see immediately post-procedure, the respiratory rate, heart rate, saturations, everything stabilized. His troponins, BNP, and lactate levels dropped down to half immediately after intervention. So now there are 2 devices that are approved for mechanical thrombectomy in pulmonary embolism. One is this AI-based computer-assisted vacuum thrombectomy, where they have this color light system where once you take your catheter to the clot and it has sensed the clot, it tells you to start aspiration. And once it has aspirated the whole clot, the light again turns, changes color, and it tells you that it has aspirated all the clot. It does not want to waste the blood that you keep aspirating out. So this is AI assisted. So all you have to do in this is you take your normal J wire into the pulmonary artery, take a multipurpose catheter, exchange it to an implant super stiff wire, and you take the catheter in. Once the catheter reaches into the pulmonary artery, this catheter then no longer requires a wire to change its shape. You can change the shape and maneuver it wherever you need to take it. So you go onto both sides, you can see how the catheter is being directed upwards, downwards. You can change it the direction as you like. So this is the penumbra system that I just showed you. And that's the clot that came out. The other device that has been approved is Inari. This is the float reverse system. So you can see there are 3 catheters shown here. One is a 24 French catheter, which is for the main pulmonary artery. Second catheter is a 20 French catheter. If you need to go distal beyond the main pulmonary artery, through that 24 French catheter, this is a longer length 20 French catheter, and it has a curve there so that you can take it wherever you like. If you need to go still further distal, there's a third catheter, which is a 16 French catheter that goes through that 20 French catheter, and it is longer in length, so it goes and reaches wherever it is required. Once you've done all of this aspiration, if still there is some clot residual over there and you need to pull it out, it has got other devices with it, which are like, you can see that device there, or they've got discs which scratch the clot and bring it out. And what you see at the bottom is the flow saver. So the blood comes into this flow saver, it retains the clot, and you give the remaining blood back to the patient. So they don't want to waste blood. So this is how it works. This is the trigger system, and these are the discs that come with it. If the aspiration is not successful, then you can use these. So you've just taken this reaches up to the clot, and then you remove the dilator, you put the manual aspiration. This does not have an AI-based vacuum aspiration computer assisted. This is manual aspiration. You remove the clot, And once the clot is done, if there is still remaining clot over there at the same site, then you need to bring in those discs to take the clot out. The benefit is no lytics given, so no chances of intracerebral bleed. There is no chances of, you've left nothing behind, so those chronic sequelae and everything, the chances are really reduced. So you will see the clot being removed now. So these discs even come in different shapes and sizes. So this is how they make the drawings, and they've planted the clot over there to show where all they've extracted, and you can see how quickly the parameters have improved. So do we have data behind all of this? So now this is USA data flash registry of 800 patients, and what they've shown is they've included 8% high-risk Ps and 77% intermediate high-risk Ps in this group. The MACE was 1.8%. There was 0 device-related complications, and the other thing to be seen is, you can see here in this pink bar that the supplemental oxygen saturation pre-procedure was required in 90% patients. It dropped down to 28 after the procedure. The need for medical ICU was reduced to 1 day, and in 60% patients, they did not even need an ICU care, and in 3 days was the median time after which the patients were discharged and they went home without any sequelae. This is Flash Europe registry. Had 40% high-risk patients. Interesting thing to see over here is 35 minutes procedure time. 35 minutes procedure time, and you are done with pulmonary embolectomy. The reduction in mean pulmonary artery pressure, the RV size reduces immediately, 1.8% MACE even in this European registry, and the dyspnea score has really improved. FLAME study, another big study going on, and it was stopped prematurely. Why it was stopped? Because look at this, in the FLAME group where we used the flow retriever, the mortality and MACE was 1.9% versus the other group which was conventional management, and it was 28.5%. There's a STRIKE P study going on of 600 patients. The first 150 patient results that have come out are again positive in favor of doing mechanical thrombectomy. Ongoing trials, STORM-P trial, 100 patients. Peerless study, which is on 700 patients. Peerless 2 randomized control trial is enrolling patients now in US. This is 1,200 patient study going on. So the guidelines haven't changed as yet. The new guidelines are about to come out, but this is a consensus paper that has come out recently. You can go through that. It gives the role of mechanical thrombectomy. So just sharing the algorithm that is being followed by the West, where they have mechanical thrombectomy facilities available. So if you have a patient with RV dysfunction, raised biomarkers, then you need to see if he's hemodynamically, blood pressure is stable or not. If the blood pressure is not stable, he falls into the high-risk PE group. If you have a cath lab and mechanical thrombectomy service available, he just goes for mechanical thrombectomy. There are no lytics for this patient. If you don't have a cath lab facility for this patient, only then the patient goes for lytics. If the patient does not show improvement in 2 to 4 hours of lytic therapy, patient needs to be shifted to a service where they can do mechanical thrombectomy. In the intermediate high-risk group, the pressures are stable, but if the patient has high lactate levels, he has got tachycardia and other features that are given in the box, he still goes for mechanical thrombectomy, no lytics for him. If he does not have these features, then he goes for anticoagulation therapy. And if within 12 to 24 hours of anticoagulation, the patient is still stable, but the parameters are not improving, he still goes for mechanical thrombectomy. So, coming to the last slide, there are 3 life-threatening blood clots. STEMI, we used to treat them with lytics, now we do primary PCI. Acute stroke, we used to treat them with lytics, now we do mechanical thrombectomy. Pulmonary embolism, we used to treat them with lytics, we are still treating them with lytics, but the paradigm has changed. The West is now moving towards mechanical thrombectomy. The evidence is there, and I'm sure the guidelines are going to change very soon. So with everybody sitting here who matters, I think this is an area we really need to look into. Thank you very much.
Question answer session will begin now. If there are any questions, you can please.
Thank
So I
you.
think we'll start with Ali Raza Sahab. He wants.
Sir, thank you so much, and I'm glad you have taken it on board because I know that stroke you took and now pulmonary embolism as well. So,
The mic is not.
Achha, sorry. So I'm glad you have taken it on board because I know that you will take it somewhere from here. Pulmonary embolism, we tried it as well, and we wrote to a few people. We wrote to Penumbra, we wrote to Anari people as well, and I think the catheter, the costs, we look at the costs as well because I know in Euro PCR we went on these booths and looked at it. I think it's a very well required. The only thing is about that the companies, we need to convince someone to get these catheters down because in my understanding, Anari is the best system for it at the moment. What do you think, which devices are the best for it at the moment?
So the data is positive for both of these devices. The only thing is the biggest catheter that Penumbra still has is a 20 French catheter. Whereas with Inari, they've got a 24 French, and then they've got those devices also with which you can really take it out. So I looked up the costs. So in UK, this Penumbra system for one patient costs, for the disposables, it is £4,500. And disposables for one patient with Inari is £6,000. So the costs are still high, but they are in real big demand now in the West. And I think soon, we will also move towards that side, and the cost probably will come down. PIC doesn't have cost issues yet.
Yeah, wonderful. Great talk, Asim bhai, and very well scripted. You really had our attention all the way. But for the time being, like you said, we just give the heparin and so on and so forth and wait it out. The perfusion catheter, when you give it and you ride it on the wire and in the middle of a thrombus, and you infuse it with the TPA, TPA is now very commonly available. We should not consider it as an expensive or rare drug. If given in the infusion care 24 hours, they've shown that it dissolves everything. And so I think for those of us who do not, I think it will be some time before we gain access to it. But perfusion catheters are available. Yeah. So having a perfusion catheter, infusing TPA in the middle of this thrombus is very effective, and people have shown that also. So while we're waiting for this wonderful device to happen, that is an option we must all think of.
The question on that trial was this, that the mechanical effect of the catheter actually causes more advantage than you giving the TPA at the exact point there, because I was present in that discussions, and they said that it's usually when you reach the catheter there, you usually use a catheter, you cause some disruption there actually. And then the cascade mechanism of it works later on. So advantage wasn't that clear whether it's just pure the thrombolytic. Obviously there will be advantage of it, but the mechanical effect of it as well.
We're talking about different things, like no mechanical thrombectomy has shown evidence of, at least in coronaries. But people try to use the same device in the pulmonary. And that's where that data was brought up, that there was disruption by the device. But this totally, they just put the wire in, push the perfusion catheter, and it's so simple as that, and attach a perfusion, the infusion pump, and that's how it all works. No, you're not aspirating. You're infusing. You attach it to a infusion pump and infuse PTA, TPA in middle of the thrombus, and it dissolves it away.
Sir, thank you very much for a wonderful talk. Sir, just wanted to ask that does these catheters have a role in IVC thrombosis, extensive IVC thrombosis who have not developed pulmonary embolism yet, but who are at high risk of developing pulmonary embolism, like we see cases who have extensive thrombus involving the renal veins and the IVC? They can be used in such cases, or just they should be treated with the anticoagulants or NC2 lytics, as General Sohail Aziz had
So
pointed.
for DVTs, for IVC thrombus, there are other devices also that can be used. You've got angiojet that can be used. There are many other devices that can be used. But for pulmonary embolism, previously angiojet was also being used. Now it's not licensed for it anymore. These are the only two devices licensed for pulmonary embolism. On the way back, what they've done is, on the way out, if there is extensive DVT or IVC thrombus, they do remove it with these catheters on the way out. They're using it for this purpose. But dedicatedly, it's for pulmonary embolism.
So one more question. I really appreciate for the excellent talk. I want to ask, suppose we are seeing all the things in the right now videos not available in Pakistan. What do you think about very small size thrombus present either in the saddle branch or in the some part ahead, about choosing the intracoronary thrombustor in case we can just track the things out, whether it will help or not, or have you ever experience with it before?
The use of thrombustor in pulmonary embolism?
Yeah.
So that's heavy clot burden sitting there. Even for stroke, the coronary thrombustors don't work. Coronary thrombustor is only good for the coronaries. You can't extract anything else, anything bigger in DVTs, Ps. It doesn't work. It's too small a catheter. So that's a 6 French catheter. But what they've seen benefit with is 24 French catheters, 20 French catheters. So 6 is, again, very small for it.
Sir.
It is a venous access.
Sir, we at AFIC Cardiac Surgery Department, we had a patient with chronic thromboembolic pulmonary thromboembolism, and that was a very young patient at 27 years of age. In our management and in our scoring system, we never talk about the left ventricular function. That patient has a very poor LV with 15 to 20%, in addition to the all the compensation and decompensation on the right side. We proceeded with surgical thromboembolectomy of that patient, and we had everything, ECMO and everything. I think there are many other aspects. We don't have much data available. We are still quite... I think we need more time and more data should be collected, especially for the post-operative management of these patients, whether we are doing it by mechanical thromboembolectomy or by surgical thromboembolectomy.
So this is an upcoming specialty. Yeah. You will see more and more data coming in. Large trials are being done, 1,200 patients, 1,500 patients, randomized control trials, because the initial trials are really positive for mortality and morbidity in pulmonary embolism.
So
you'll see more data.
Any scoring system on the left ventricular?
The current scoring systems don't involve it.
They don't involve it. Thank you.
Sir Asim, a very excellent presentation. I have a question for you. Is there any case reported for fat embolism and amniotic fluid embolism, because we cannot give thrombolytics in those cases?
With these devices, no. These are dedicated thromboembolic devices.
I definitely support in what you said, and I get report cases from my son, who is teaching me cardiology now, that he has used both in penumbra and NRE. And when he uses in the cases, the amount of clot it can extract is tremendous. So there are cases in which heparin will be good, there are cases in which thrombolytic will work, but then there are cases which we lose perhaps in which NRE or penumbra, and perhaps these both are complementing each other. So most centers have both of them. And in US, they don't have problems because those machines are brought in by the reps, but we probably have to procure it, and definitely we have to go this way. Thank you very much.
Thank you very much, sir. Thank you very much, everybody.
Thank you very much. I think there have been very excellent presentations and wonderful discussions, and at the same time, I think this kind of thrombectomy, this is very, very fascinating, but at the same time, it's very costly. So I think considering the constraints of the economy, I think we'll go for these kind of intervention and the devices in future. Once I think each of major center in every province should have this kind of facility with them available, because it should be available. If someone, the head of state or someone else comes and visit Pakistan, and if he has this kind of a problem over there, you don't have this facility, then you're gone. So I think we should have it, and hopefully I think next financial year, they will have the kind of a budget where they can, I think, fund us for these kind of facilities. Thank you. We are already late for the lunch, so let's go for the lunch and prayers. Thank you.